Good morning, everybody. I'm Jennifer Linden. I'm an athletic trainer at Emory Sports Medicine, and I work in the clinic with Dr. Gleason. I do have a background in gymnastics and entered the sports medicine side of gymnastics in 2007. Gymnastics, dance, the performing arts all hold a very special kind of place in my heart. I'm going to start the morning with some terminology of dance, just things to kind of keep in mind as the other presenters speak throughout the morning. So we'll start with most basic or most common types of dance, some body positions, and some basic skills. So let's get started with ballet. Ballet is a rigorous style of dance that is the foundation of most forms of dance training. It's a highly technical form of dance that requires ankle stability and core control. There are several styles of ballet and methods of instruction. Just kind of depends on where you live or what school that you attend. As to which style of ballet or method of instruction that you are introduced to. Ballerinas are female ballet dancers. They can wear either soft-soled shoes or point shoes. Male ballet dancers typically do not wear point shoes, although they do like to play around with it sometimes. Tap dance is a form of dance where the feet are used as percussive instruments. Tap shoes have taps or metal plates on the toe and the heel of the shoe. The two most common forms of tap dance are rhythm tap, which is more musically driven, and Broadway tap, which is more dance and movement driven. Jazz dance combines several styles of dance into a highly energetic routine that lacks the conventional boundaries of, let's say, a ballet. Jazz promotes a sense of individuality while highlighting the skills of the individual dancers. Jazz shoes have a split sole, which allows for a bit more motion of the foot while dancing. Modern dance and contemporary dance are very similar. Modern dance was first created as a rebellion to the classical ballet. It's a raw style of dance that is an expression of the dancer's relationship with the floor and their own breath. Modern dance typically is danced with bare feet, but it does allow for a variety of shoes as long as there's freedom of movement of the foot in that shoe. Contemporary dance embodies ballet, modern dance, jazz, and lyrical dance. This technique is based in ballet or jazz, but allows for movement creation and expression like a modern dance would. Contemporary is currently one of the most dominant genres of dance throughout the world. Dancers often wear a lyrical shoe or dance barefoot. Lyrical dance is also based in ballet, but it has merged with jazz and a modern dance. It's extremely technical and dynamic, but allows for focus of emotion, kind of conveying an emotion through the movement of the human body. Lyrical shoes offer protection at the ball of the foot, but allow for full motion of the foot while dancing. Hip hop originated as a street style of dance that was freestyled without any kind of prearranged choreography. It's open to personal expression and includes lots of styles such as popping, locking, or crumping. Hip hop is now practiced in both studios and street spaces. It's typically performed in sneakers, particularly high top sneakers. All right, breaking combines a dance like hip hop with acrobatics. So breaking is competed in battles. It's either two groups or individuals competing against each other, and they're judged on creativity, personality, technique, performativity, variety, and musicality. There are 4 basic skills associated with breaking, and I'll come back to these at the end, but it's top rock, down rock, power moves, and freezes. Breaking was provisionally added to the 2024 Olympic Games. It's one of the 4 sports that was added with the goal in mind to keep or to bring some youthfulness to the games and to the audience of the games. It was successfully added to the 2018 Youth Olympic Games, although the U.S. did not enter breaking in those games. Irish dance, which is surprisingly popular around here, is a traditional dance style originated in Ireland and popularized by river dance. It's characterized by stationary arms and rapid movement of the foot and legs. It can be performed with hard-soled shoes or soft-soled shoes, depending on the style of Irish dance that is being done. Ballroom dance is defined by classical overtones and includes over a dozen types of steps. It can be social or competitive. It includes extremely technical steps that are performed with a partner, typically in a large hall. Women usually wear a shoe that has a 2.5-inch heel and a suede sole because that allows for a little bit more grip on the floor while kind of free flowing. All right, let's get into some body positions here. Oh no. All right, so some body positions at the toe, some toe point. So this one here is going to be your toe point. The idea is to have a straight line from the knee all the way down to the tip of the toe. You do want it to be a straight line though, no sickling. So you don't want your big toe pointing in or your sickling towards the outside. And it should be a nice graceful line, no kind of curling of the toes underneath. A flexed foot is the exact opposite. So you just want the foot kind of straight up in the air. This is used quite a bit in attitude type positions or to show kind of a different body position within the same kind of skill. Coming up on releve is just standing up on your toes. So in soft-soled shoes, that's going to be up on the ball of your toes. And then in point shoes, it's called on point. So that's coming up on to the tips of the big toes. And there is a toe box in those shoes to stand on. And then turnout is just that 180-degree straight line from big toe to big toe, standing with the heels together. These are your 5 basic body positions in dance. They do include the arms and the legs in these positions. These are very basic positions that are taught from a very early age in dance. And then just a couple of other shapes to consider here. So these are just showing different positions of the legs, either in front of the body or behind the body. And then arabesque can be done in either of those positions as well. So arabesque is with the free leg is straight, and in attitude, your free leg is bent. All right, so some basic skills. Your dance squat, but please don't call it a squat, is a plie. It can be done in demi-plie, which is going to be kind of this partial squat here, or grand plie, which is kind of a more full squat. There are lots of different styles of plies as being shown here in this animation. But it's a plie. It's very kind of technical. Which way the feet are turned kind of depend on the style of dance being done. So some leaps, that's going to be kind of a jump and a split in the air. So your grand jeté is just your basic split leap here. Your tour jeté incorporates a turn of the body while doing their split leap. And your cabriole is more of a jump with a split of the legs, but it's still landing 1 foot at a time. Some turns. So turns can be done kind of both feet connected with the floor or on a single leg. So your chaîné turn is very quick. That's your very quick turn all the way around the floor there. Your piqué turn is very similar, although one leg does get picked up. Your pirouette is your basic kind of turn. It can be done just one singular pirouette turn, or as shown here, several in a row. And then your fouette kind of takes that to a more advanced setting. Some basic steps. So I just wanted to include this tap step here to show kind of what is required of the foot and ankle, even during just a basic tap step. There's quite a bit of dynamic involvement at the foot all the way through the foot and also through the ankle during these steps. Your closed position for any of your partnering dances, like your ballroom dance, is a very important position. The difference here being that there needs to be quite a bit of core control, but also stability through the shoulder blades to kind of keep this position the entire time. And then this is a jump done in Irish dance. It's called an overdown. The goal is to jump as high as they can to maintain this position for as long as they can, and then land as soft as they can. But all of this is done with the arms in a very stationary position, so there's no lift with the arms to get a little bit higher. All right, back to the breaking. So your top rock, which is shown here, is just kind of a rocking back and forth of the upper body. The feet kind of go with it to kind of rotate side to side, but it's more of an upper body show of movement. Your down rock is more of a lower body show of movement. So you'll go from this side to kind of the other side or in and around. But either way, it's more motion of the lower body. Both of these are kind of used at the beginning of a series of skills. Your footwork and your power moves are your bigger wower skills. This is more kind of judged by the judges and the creativity side of things, kind of get the audience involved there. And then your freezes just show kind of a hold at the end of a power move. So this is kind of a spinning in and then a freezing there at the end. The thing with breaking compared to like your typical ballets or your jazz dance is this is a lot more upper body involved. So you're still going to have lower body injuries, but this is a lot more shoulder, kind of upper back and core control involved. I also feel like we're going to have a bit of an influx in these types of dancers over the next 3 years as they figure out qualifications and start getting into it for Olympic qualifications. All right, so I hope that was those are some things to keep in mind throughout the morning. If you have any questions, please feel free to ask, and I hope everybody has a good day.
I'm not clear if this was I'm not sure if this was an old stadia process that broke or an os trigonum, but obviously has this large area in the back causing pain. And so, oops, there we go. And it's really interesting. And I wanted to pull up this cut of his CAT scan because you can see the intimate relationship between an os trigonum and the FHL. This sort of U-shaped area here in this soft tissue that you can shadow, you can see is the FHL tendon that's running in the back. And it really does show how intimate the relationship is. And so thinking about posterior ankle impingement, it's common in sports that require frequent hyperplantar flexion. And one of the things when I was doing research for this talk was that up to 12 times body weight can be put through the back of the ankle in some studies. And so there's a lot of stress and pressure back here that can definitely lead to some pain. And so, you know, how do we think about it? This is a great article by Bill Hamilton. Let me just go back one slide. He's sort of the godfather of orthopedic care for the dancer. He was the orthopedic foot and ankle specialist at the Hospital for Special Surgery, took care of the New York City Ballet for a long time. And this was sort of the first orthopedic description of this posterior ankle pain. And again, he really demonstrated that intimate relationship between the FHL tendon and the os in that area. And if this is impinged or inflamed, and then he talked about this important fiber osseous tunnel, which I do think plays a role in sort of why dancers can get pain in the back and understanding. And so what is the etiology of the pain? It can be just soft tissue. It could be just scarring of the posterior capsule. It could be scarring of your ligaments that attach in the posterior aspect. A lot of times it is that FHL tendon, which could have a tendon tear or tenosynovium. But a lot of times it's an os trigonum, which is a free loose body back here, or what's also called a stadia process, which is just a prominence of that tubercle that's healed on and can lead to sort of changes at the subtalar joint or at the ankle joint, depending about how the prominence is. And so how do we assess these patients in the office? Often they've seen non-operative management or therapists before they come to see us. They often have vague pain that's deep inside. It's definitely worse in positions of plantar flexion. We often can get compressive type pain. So I bend their ankle all the way down and push up into the heel, and you can elicit pain. But often for me, it's just poking in the back. It's feeling on the Achilles and saying that they don't have pain. And then when I put my finger either to the medial or lateral side and bend their ankle down and push, they really have some significant pain. Sometimes when you move that great toe, it can also elicit pain. And you may notice the reduced plantar flexion compared to the contralateral side. And so, you know, what do we do to image these? Often just simple weight-bearing x-rays are easy to identify that os. The soft tissue structures are a little bit more challenging and often need advanced imaging. MRI is useful to confirm the diagnosis and assess if there's FHL involvement. And this is always ordered after the failure of those first set of conservative care with rest, PT, booting, and the other options that we'll talk about. So just some MRI examples. You can see a large stadia process here that's connected with all this inflammation around it. This is more of a true os trigonum with just all this inflammation in the back part of the ankle, which can just lead to inflammation and pain. And so, why do dancers get this? This is a really interesting anatomic study performed in Germany, and they wanted to look at what the blood supply was to the FHL and wanted to determine if there were any hypervascular zones. And you can see here, there's 4 zones they looked at: one right at the musculotendinous junction, one right at the turn in the talus, the other in the mid portion in the midfoot, and then underneath the metatarsal head. And they did these vascular studies, which showed, the good vascularization in parts of the tendon, but quite poor vascularization in other parts of the tendon. And so what they really showed was some interesting findings that if you look at the tendon from superficial to deep, in the 2 spots posterior to the talus and below the first metatarsal head, which are the 2 most common places dancers will experience pain from their FHL, is that there's significant reduction in blood supply along that anterior aspect. And so that's why the deep aspect of the tendon often has a poor blood supply, often can get tearing and tenosynovitis, and certainly can contribute to pain and difficulty getting these patients back once they develop a tear or inflammation, because there's not that blood supply to provide a good healing response. And so what are the treatment options? The traditional treatments are PT, rest in a boot, nonsteroidal anti-inflammatories. For a true os trigonum with inflammation, I really love my non-operative partners to do an ultrasound-guided steroid injection. I'm not super excited when it's a tendon involvement, because I always worry a little bit about steroid injections with tendons. We're definitely trying some more non-traditional therapies like PRP or stem cell injections. But what do we do when those sort of treatments fail? That's when we start to talk about surgical management. And so when you think about surgical management for the posterior ankle that's non-Achilles, so posterior ankle impingement, you're thinking about an open versus an arthroscopic approach. And from an open perspective, there's really 2 types. There's a posterior medial or posterior lateral. I think the biggest benefit of an open approach is that I can visualize and treat any significant FHL pathology that's in the back of the ankle as well, which really can provide us good visualization. But if you sort of go lateral to the tendon, a posterior lateral approach, you have to deal with the sural nerve. And if you go medial to the tendon, you have to deal with the large neurovascular bundle. So, there's risks and benefits of both options. From an arthroscopic perspective, you have definitely less issues with nerve issues, but you can assess and treat the FHL very well, but there's less risk of wound issues and scarring. And so the number one thing for me is I typically do an open approach. I need to get these patients moving almost immediately. Post-operative day 1, they're taking off their boot, doing ankle range of motion exercises, and they're in with the therapists at 10 to 14 days, really getting active and getting them going so they don't get stiff. And so what is the literature that supports it? There's good data here. This is a great study looking at 40 ankles and 38 dancers with a really good reduction in pain by treating their os with a posterior medial approach. They had over 90% return to their previous level of dance, no significant neurovascular complications. They had a few minor wound complications. So, 38 out of 40 ankles, they had what they considered a successful result. And so I think there's good literature to support an open approach, but there's also excellent literature to support an arthroscopic approach as well. This is another study performed looking at 20 patients with 1 year of follow-up, and their Tegner score, which is a measure we use for athletes to see if they get back to the same level of athletics, and almost all their patients did. And again, a low level of complications. Can you do the FHL arthroscopically? You certainly can. It's challenging and it's often not as successful, so it's something to consider. This is an interesting study where they did 27 ankles. They had a successful result in about 70 to 75%. One patient had to have a reoperation. For me, I think, again, if I think there's enough FHL pathology to warrant looking, I think an open approach is probably the way to go. When thinking about all of these surgeries together, there's a nice systematic review which looked at and in combination sort of divided all the series up. I think the key here is the return to dance, even with the most minimal approach, is going to be 7-8 weeks. But I really tell patients it's 10 to 12 weeks if you're having surgery before you're getting back. And if you look at all the ankles combined, there's a pretty low risk. The posterior lateral had the highest issue, and this is that sural nerve. It's very sensitive on the outside part of the ankle. So if I go lateral to the Achilles, I really focus on identifying that. The endoscopic approach, again, had only one complication in all these series. But again, it's difficult to assess the FHL and manage it with that. This is a nice review of sort of how we get these patients going. This is from Chris Coetzee in Minnesota, who's a friend. And this is sort of how they get their dancers back. But again, it's sort of progressing, working up to strength. But at 6 weeks, they're starting to get these sort of patients going, sort of getting them moving so that by 8, 10, 12 weeks, they can get back out there. And sort of thinking about the goals for the dance. Oh, I'm sorry. The goals for the dancer after surgery, the first 2 weeks is getting their sort of pain and swelling back, protecting them from themselves. At 2 to 3 weeks, it's that phase where they want to initialize physical therapy. You want to get their tendon going, thinking if you've done a lot of work on the FHL, you want to protect it. And then at 6 weeks, it's really building up their strength and getting them going. So just changing gears for a second, we're going to talk a little bit about the Achilles tendon a little bit. When thinking about Achilles tendonitis, there's really two types of tendonitis. It's insertional or non-insertional. Non-insertional is the sort of 2 to 6 centimeters above that sort of lump that you feel in the tendon itself, where insertional tendonitis often is associated with this bone spur, the prominent bump on the heel, which we can often see. And so is Achilles tendinopathy common in dancers? It certainly is, according to this cross-sectional study. It was the second most common issue that professional dancers were followed in this cross-sectional study. Only more common was patellofemoral syndrome. And so there's been lots of articles sort of talking about the initial treatment. This is an article from the early 80s, another article from the mid 90s, just talking about how you treat these, what is the management, and typically it's been the same conservative stuff that we've talked about. The physical exam often demonstrate a tight gastroc muscle. They often have pain with plantar flexion, painful prominence either in the tendon or at the insertion. And at the insertion, it's interesting to try to differentiate if it's the tendon insertion or if it's the retrocalcaneal bursa. And if it is that retrocalcaneal bursa, that can often be difficult to assess if that's the painful area or if it's the posterior impingement from an os or an FHL. And so that often we do have to get an MRI or an ultrasound to differentiate. And so our dancers different. This is a really interesting study I came across looking at this. And so what they showed in this study was an ultrasound study looking at a heel rise in dancers who were pre-professional and then long-term professional dancers. And they showed that the sort of long-term professional dancers didn't have to do nearly as amount of work with the tendon to get up, but as they got stronger, their tendon got shorter. And so is that a compensatory change, or is that because they've danced for so long, their tendon is changing, or were they like that and that's why they become a better professional dancer? I'm not sure, but there's certainly some differences in the tendon structure that we see with professional dancers. This is another interesting study looking at the, kinematic effects of dancers with and without tendonitis, going through an initial contact, a flat foot, the heel off. And the interesting thing was their ankle and foot kinematics didn't change, but there were significant kinematic differences at the knee with internal rotation at push off and hip abduction at landing. And it was unclear if this is causative or compensatory in the sense that, is it because they're internally rotating that they're more likely to get tendonitis at toe off, or is it because of the tendonitis that they have this problem develop? So just an interesting sort of thought. But it's a wonder, is there ways to identify these patients earlier? So maybe get their treatment earlier to prevent them from having problems. This is from England, looked at 79 professional dancers for 24 months. And they demonstrated that about a quarter of the patients had significant sonographic changes, but only those with moderate to severe hypoechoic areas predicted the development of future Achilles problems. And so it's just something to think about as we treat these patients. And so the initial treatment is, focusing. It's topical anti-inflammatories, it's boot and resting, it's activity modification. But how do you tell a professional dancer to stay off their boot to stay off their ankle for 6 weeks, especially with the amount of challenges they put on their ankle? There's really, if they develop that sort of insertional tendonitis, there's no way to take the bump away without an operation, but there are treatment options out there. And so there's been lots of non-operative treatment, from cryotherapy to topical nitric oxide to sclerosing agents. We do some shockwave therapy in our office. We definitely do PRP and stem cells. There's lots of great options, but not a ton of literature to support any of them in a significant way other than the aggressive therapy, eccentric loading, stretching, and all those types of things. We definitely try lots of different stuff with our dancers, especially in season. but it's really figuring out how to get them to change their kinematics, their stretching, and really work on that muscle to try to help treat them to get them through. And so this is just an example of some intrasubstance Achilles tendonitis. You see the thickening, the nodularity. You see this sort of inflammation within the tendon, almost read as partial tearing sometimes, but it's just the disorganization of those collagen fibers. And so how do we treat this surgically? We open from a posterior medial approach. We identify the tendon. We take out the bad segment of the tendon and tubularize that tendon. I would tell you this is probably not a surgery we're doing for a dancer until they're sort of to the end of their career or until they can't tolerate it. We don't have any great literature on surgery and outcomes of this during a career. And so we're elliptically removing the tendinotic tissue. We're repairing, tubularizing that tendon. And I get them weight bearing at 2 weeks. I get them moving again right away. They're in a boot for about a total of 6 to 8 weeks. Insertional tendonitis, you got to think about the retrocalcaneal bursa, the Haglund's deformity, which is this prominence, and then this insertional calcification, which all have to be taken care of. On the MRI, you often see this significant edema in the bone. You see this inflammation in this area, and then sort of this thickening and nodularity of the tendon. And so there's lots of approaches to do this. I do a direct posterior approach, straight midline, peel the skin and tendon off the bone, take away the bad tendon, and then repair it back down. A partial release is just as good as a full release, and so I don't think taking the tendon off completely is necessary. This is just some pictures from the operating room. So this is after we've taken off the prominent bump. This is us placing our suture anchors in. We place our anchors in, and then we pull the tendon back down to the bone, bring the tendon edges back together, and we've shown that patients can have a pretty good result. There is definitely a paucity of literature in high-level dancers looking at sort of the issues associated with insertional and non-insertional Achilles tendonitis. And so I think this is probably that dancers are either delaying surgery until their career is over, or there's just sporadic cases of it. I can only find one case where they described what the post-surgical care was, but no outcomes were associated with this article. Just for a minute, we'll talk about an Achilles rupture because I think some of the literature supports sort of how Achilles tendonitis and tendinosis is treated. It's the dreaded pop. The tendon, it sees 8 times body weight. There's often inflammatory changes that can contribute. Most ruptures occur without prodromal symptoms. You can see a rupture here where the tendon edges are completely apart. There's an intact peritoneum. And so how do we treat this? Often for high-level athletes, it's open versus percutaneous. The benefits of surgery is a decreased re-rupture rate, increased strength. An open repair has less nerve injuries. A percutaneous repair has sort of less risk of infection, and really it's surgeon dependent. I tend to do an open repair, a mini open repair, in about a 3 to 4 centimeter incision. We repair the tendon edges, bring them back together, and repair them, and then get them into a splint and equinus for 2 weeks, and then get them weight bearing sooner. This is a percutaneous technique. The biggest challenge I have is you're passing suture blindly, and that sural nerve, as we talked about earlier, can be challenging. But there's good data that support both techniques. Our rehab, and so the rehab is sort of the similar for both types of patients. You want to get them weight bearing early. So me, it's at the 3-week mark. I get them out of their boot at about 8 weeks, and I want them single-limb toe rising by 12 weeks. But I think the outcomes in athletes are going to be different than non-athletes. We did an interesting study looking at the strength following Achilles tendon repair. And it did correlate that the stronger you can get the tendon, the more likely they are to get back. There's good data to support either technique, but typically athletes don't return to the same level of function. You know, all stars become starters, starters become bench players, and often bench players become career ending. And so it's definitely a challenge for patients to recover. And I think surgery on an insertional or non-insertional will have some of the same limitations. This is a nice retrospective review looking at all types of athletes. And basically a quarter of athletes never got back to playing professionally again after an Achilles rupture. But their return to play is much longer than the average person. The average person comes in, I tell them 4 to 6 months, they're back to playing soccer or doing those types of things. My professional athletes, I'm telling them 10 to 12 months before they'll be able to compete fully. In the last minute or two, just want to talk about some uncommon problems you don't want to miss. A calcaneal stress fracture can be really challenging to recognize. It often has that same type of pain. I think the biggest physical exam finding you'll notice is if you squeeze the heel on the inside and the outside, it often causes pain, where insertional tendonitis causes pain in the back. or if you poke in the back. So if there's pain on both sides of the calcaneus, look for this dreaded line. And this often causes a prolonged period of rest to treat. You can often get ganglion cysts in the back as well. Just something to think about. You often pick this up with the MRI, and sometimes you just have to go in and take this cyst out. The challenge is these can often recur because they're an outpoaching of the synovium. Another one to think about is exertional compartment syndrome. It's a vague pain that increases as activity increases. They often have poor exercise tolerance. The pain goes up and down the calf, but there's not really those classic changes of a tendonitis. You may want to think about it, and often we can do exertional compartment testing to figure it out. Anterolateral and is more common, but it can occur in isolation posteriorly as well. So our case review, this is our young athlete. Again, he's got this prominent os, painful. You can see it on CAT scan. We went into the operating room. The key here is have to be super careful of the posterior subtalar joint. I saw when I was a fellow, a professional soccer player from Ireland whose career was ended because they got into a subtalar joint and he got really bad arthritis here. You can see that once we remove it, you can really see that we remove it nicely. You can see that prominence is gone. And it's a big piece. It doesn't seem that big on x-ray, but this piece was almost 1.5 centimeters by almost 3/4 of a centimeter in size. This is just a video. And you can see, and I apologize, I worked on this yesterday, but that's the FHL moving right there. This is where the piece was. And you can see the FHL is intimately associated with that area. And so just an example of how close it is and how you can access the FHL with a nice open approach. Oops. And so in summary, thinking about posterior ankle impingement, think about the bony and the soft tissue causes. Insertional and non-insertional tendonitis are big players. Really want to recognize them early. Achilles ruptures, I think, give us an idea of what surgery would look like. So non-surgical management for those tendinopathies, and always think about those uncommon causes. Prior to my email here, please don't ever hesitate to reach out if there's questions about patients, my office and cell phone number. And I think I'm going to put a plug in for research. Me and my team here, Dr. Coleman, you'll hear later, are always looking for research collaborators. Any research ideas you have at all, we would always be willing to participate. And thanks for letting me talk today.
Dr. Barito, thank you so much for that wonderful discussion and talk on posterior ankle impingement and the dancer. Our next speaker is Val Schomburg. Val is a registered and licensed dietitian with a master's degree in nutrition science from the University of Minnesota. She is board certified as a specialist in sports dietetics, a certified menopause practitioner with the North American Menopause Society, and a fellow of the Academy of Nutrition and Dietetics. She owns Enlighten You Nutrition Consulting, a private practice in Atlanta where she specializes in nutrition for recreational and professional athletes, dancers and performing artists, women in midlife and menopause, and individuals with disordered eating concerns. She is also a consulting dietitian at Emory. Originally from Minnesota, Val's experience and expertise come from years of practice in many settings, including eating disorder treatment, Division I college sports medicine, professional dance settings, and speaking regionally and nationally on numerous nutrition-related topics. She is passionate about providing nutrition care to populations vulnerable to disordered eating and promoting positive nutrition messages that help women make informed decisions about their health and live a life where they feel free to confidently embrace their best unique self. She is going to speak this morning on nutrition, what every dancer needs to know.
Thank you. Thanks, Dr. Gleason. I will share my screen and we'll get started. All right, so thank you again and good morning, everyone. I'm really excited to talk about nutrition for dancers. So I want to start by just setting the stage in terms of nutrition really makes an important difference on your abilities as a dancer, performance and health. I mean, ideally, we're always working to improve performance, and nutrition plays an important role in that. But part of how that happens is by nutrition helping that muscle tissue recover and have metabolic adaptations to the activity that you're doing. And although dance is a weight-bearing activity, we need to have appropriate nutrients to help those bones stay strong, as we've just seen a lot of not only bone, but even soft tissue injuries that can come along. And nutrition plays an important role. Nutrition is really important for our brain and helps with concentration and balance. So being able to focus, whether it's with choreography or a really long training session, and staying, good with your skills and your form at the end of a training. This is often where we see some injuries happen, is when you're fatigued or just, kind of wore down. So nutrition plays an important role with fatigue. And as we've seen, we want to do everything we can to reduce injury rates. And depending on a dancer's age, nutrition is really important to make sure that we're sustaining proper growth and development. So for today, then, I'm going to talk about a few principles that I think dancers really need to be aware of. First of all, what, when, and how much to eat and drink. We'll talk a little bit about nutrition for competition or performance, and then how to balance the aesthetic demands of dance with health, and then we'll put it all together. So what to eat? I would hope that this would be pretty straightforward and simple, but in today's diet culture, it's just not so straightforward anymore. So we really do need to have a balance of all these different macronutrients, carbohydrates, proteins, and fats. Despite popular opinion in today's culture that carbohydrates are not good, dancers really do need plenty of carbohydrates to fuel dance. It's an anaerobic activity in many, the start and stop, the leaps, turns, all of that is really more intense activity. And carbohydrates are an efficient and preferred fuel source for the muscles as well as the brain. So making sure we're getting that balance of whole grains, as well as fruits and vegetables. Then we also need to have some protein. Good sources of lean protein can vary from meat, poultry, fish, soy, whatever your food choices are, but we need to have those proteins for that muscle repair after doing a bout of intense activity, as well as rebuilding that tissue. And protein is important for your immune health as well as bone health as well. And then finally, fats. We need to have fatty acids. Some people still have this belief that eat fat, get fat, and that's not true. Fat is really essential to our body. Every single cell membrane is made up of fatty acids, and so we need to have a balance of nutritious fats. Fats help us absorb fat-soluble vitamins, vitamins A, D, E, and K, which we talk a lot about in terms of overall health and performance. So we just need to continue to remember that we need to have these balance, and anytime we're excluding a food or a food group, it could be problematic. And then hydration. We need to make sure that we're drinking plenty of fluids, recognizing that the body is almost 70% water. A lot of that is based on your muscle composition. But if we're dehydrated and we're showing up to practice or training and we're in a state of dehydration, there's a number of symptoms and problems that we can have with that. So strategies for making sure that you stay well hydrated. You can see on the picture on the left, you can use some type of a water bottle to keep you on task, as well as, I'm often asked, like, well, how much should I drink? And there's a lot of different formulas out there. And besides just doing a really expensive urine specific gravity test, really just if your urine is a light, pale, yellow, lemonade kind of color, then we probably are in a good place of hydration. If you're getting really dark urine, especially in the morning, then that probably suggests you're dehydrated. Okay, so next principle, when to eat. And this depends on your day, what your training is, what time you're doing your dancing, as well as what's your lifestyle. So just some rules of thumb to keep in mind is that if it's about 3 to 4 hours before dancing, your body can tolerate probably something in the neighborhood of a regular meal, which would include some protein, some good carbohydrates, and some fats. So that might be some scrambled eggs with veggies and buttered toast, or a sandwich, fruit and veggies and yogurt like you see pictured here, or something like rice or quinoa with beans or chicken, roasted veggies. Some of those are just really easy meals to prepare. And then If it's a situation where it's a couple hours before and you still need to make sure you have something to eat, this might be in between performances. So you're just getting done with a performance and then you have a couple hours before you perform again, and you really need to not only recover and refuel, but also have something to ensure that you're fueling for the next activity. Maybe something a little bit smaller. Still something that has some protein and carbohydrates would be okay. We just want to make sure we digest that. So yogurt with granola and berries. Some people like that idea. Peanut butter and jelly sandwich, or even something as simple as a bowl of cereal. Or you could do like an overnight oatmeal and bring it with you with some nut butter and banana. As we get closer to dancing, we want things that are more easily tolerated and quickly digested. So things that are higher in fat, fiber, and protein are going to be a little bit hard on the GI system. And some people tolerate that well, and that's great. We certainly want to be able to do some gut training as well. But in general, we focus on things like liquids and smoothies, or fruit like a banana or crackers, animal crackers, graham crackers, and fig bars are some examples of a light snack that you might have before dance. And then we have to think about recovery. So right after dancing, 30 to 60 minutes after, we want to refuel those muscles with protein, so for the repair and recovery, as well as carbohydrate for glycogen. Glycogen is the name for basically that fuel tank in your muscle tissue, which is where our body accesses those carbohydrates. So you can see some examples here: peanut butter and banana roll-up, easy to pack and bring along. Something like tuna salad with crackers and fruit, put in a little easy Ziploc container, or a protein fruit smoothie, something you can make ahead, freeze, bring it with you, and it might be thawed by the time you need it. Next, how much to eat? Well, this really depends. It depends on age, where you're at in development. It depends on many different things related to body composition. And then, just as we saw in our first presentation, it depends on what kind of dancing you're doing. How often are you dancing? What is the intensity of your dance? You might be more physically working harder than maybe the person next to you. So kind of recognizing, what is varying in terms of a class, or how hard you're working. And then how much time are you putting into this? How much time in terms of the dance per class, and even in terms of if you're doing additional training. And so again, there's really not a one size fits all approach to how much to eat. And this slide just illustrates, again, to keep that perspective in mind of how many classes are you doing that are more of a low to moderate intensity. Some classes and some types of dance are going to be higher intensity, or different times in your year or your season. So we call periodizing nutrition is this idea of, boy, if you're leading up to, say, a nutcracker performance or some type of a production, you're probably doing a lot more training, longer rehearsals, and even in a day-long competition, your energy needs may change. So in that case, if there's something in the neighborhood of some hard training, well, what would we do? This is just a picture that illustrates how your plate might be half of your plate is those whole grains, those energy producing nutrients or foods such as oatmeal, bread, pasta, rice. And then a quarter of your plate might be different sources of protein, and a quarter of the plate, some of those fruits and veggies. If you're in a season where you're doing more light training, then contrast to that, you might have a half of your plate or more of the fruits and vegetables, a quarter of your plate, your grains, and a quarter of a plate are some protein. So what about nutrition for competition and performance? And no matter what the athlete, people always want to know, what should I eat the day of? And that is really important. But what we also want to talk about is what to eat in the days leading up to what your event. So we want to make sure you're eating enough, especially when you might have some long, intense rehearsals, which are often depleting those muscle glycogen stores, that fuel tank. So if we show up to the day of the performance already depleted, that's problematic. So really avoiding restricting intake. And if you're worried about stomach or GI discomfort on the day of the event, you might try a lower fiber diet. Fiber containing foods are things like beans, certain vegetables. And so we might just reduce those and replace that with some other sources of energy producing carbohydrates in the day prior to the event. On the day of your performance or competition, you really need to have a plan, and a plan that you've practiced, that you know is well tolerated. You know the timing of that meal that's about 4 hours before the warm up, even before your performance, and even in the case of having a snack, maybe at intermission or in between performances, what that looks like for you. And ideally, packing your own foods and drinks and bringing those along. You might need to plan ahead for a recovery meal after the performance, especially if you're not getting off the stage until 11 p.m. Really ideal to have something there to help you recover. Okay, what about some of the aesthetic demands that dancers face? This is a study by Dr. Nikki Kay that just was released at the end of 2020, and it's really an interesting study of professional ballet dancers. It was almost 250 questionnaires, dance-specific questionnaires. And one of the pieces of information that they obtained from this research was that 44% of females and over a third of males dancers reported being told to lose weight at some point in their training or professional career, mainly by teaching staff and directors. But many of these dancers were also influenced to some extent by social media in trying to lose weight. And so part of the problem with this is that pressure, whether it's self-imposed or being told to lose body weight or decrease body fat, often contributes to some restrictive eating. And we end up in this cycle of potentially under eating, feeling cravings or hunger, that whether it's having 2 cookies that you think is a binge, which keeps the cycle going, or binge episode that contributes, that is something that is eating an amount of food that you wouldn't normally eat. That can be one problem. The other problem with this is this concept of energy availability. So whatever you take in for fuel, the body preferentially uses that for your training. And then the amount of calories or energy left over that's available for all your other body functions is what we refer to as energy availability. And as you can see on the picture on the right, if you don't have enough energy left over to pay all these bills, if you will, like these are the essential things that your body needs to be able to do, which is fuel your brain, your digestive system, your reproductive system, etc., you're going to start to experience some symptoms. Some of that can be irritability, anxiety. One of the most prominent things I see with dancers is gut dysfunction. So kind of like constant complaining about bloating, constipation, diarrhea. And then what happens is someone recommends that they take out another food group or that they follow a low FODMAP diet or something like that. And in some cases that might have some efficacy, but in general, it's probably contributing to the problem. So again, in Dr. Kay's study, 57% of those dancers and almost a third of the male dancers had the psychological, physiological, and physical characteristics consistent with a low energy availability, which we often refer to as REDS, which is relative energy deficiency in sport. And so we know that the longer this low energy availability situation continues, the harder it gets to restore health. And so it's really thinking about it in terms of, it might show up as an injury with a stress fracture or some tendonitis, because your tissues have to have nutrients to keep them strong and healthy. How do we treat REDS? It's really multifactorial. And of course, this is a really busy slide, but I just wanted to demonstrate that there's a number of things that we need to address. It's not just eat more calories and gain weight, which I think is what kind of freaks people out and gets scared. But it's recognizing that in some cases, I have individuals who are over consuming fiber. Fiber, we think of beans, fruits, vegetables are really good foods for us, obviously, but too much of a good thing isn't always a good thing. And if you're trying to restrict your intake for whatever reason, sometimes it's unintentional. We often see unintentional under eating. And so we just really need to address all of these different parts to get you back to a good energy availability. So making sure that we're eating enough also ensures that we're getting key nutrients. So on the left, a couple of the nutrients, calcium and vitamin D, are essential for our bone health. Some really active individuals often suffer from iron deficiency or iron deficiency anemia. So we want to make sure that we're eating a balance of those foods especially if you're trying a vegetarian or vegan eating pattern, which is totally fine. But again, we need to make sure that we're getting enough iron containing foods on a regular basis. And even something like omega-3 fatty acids, really helpful in terms of overall health. So when I'm asked about supplements, what I want to say is that you can't out-supplement a bad diet. So vitamin D is an example of where we often need to supplement, and is often recommended because it's hard to get these foods from food. We often get it from the sun, and dancers are inside all the time. So that makes sense. But really emphasizing a supplement on top of focusing on your diet first. Okay, so wrapping it all up, putting this together. So you can know all this information. I could tell you what to eat, but ultimately we have to practice what I call the 3 Ps. We have to take time to sit and plan. What does your week look like? What is your schedule? You got to get to the store and get good food in your house so that you can follow up on your plan. And then we have to find time to prepare these foods. And we can certainly use things like Instacart to get the food a little bit easier. We can use meal kits, many different strategies to simplify this. This doesn't have to be Instagram worthy and all perfect, correct, and right, but we do have to make sure that we're fueling our body well. So remember that food is your primary source of fuel for your body to do the work that you're doing. And you might need to do some help, or you might need to get some help with determining what, when, and how much food is best for you, for your specific training and your development and what you need. Figuring out how can you do some of those behaviors to help you plan, purchase, and prepare your food, and really emphasizing performance over appearance as much as we can. So many different factors come into helping a dancer be healthy and dance healthy. Obviously, great training, recovery, self-care, and sleep. And nutrition is just one piece to that puzzle that can, and an important piece to help you dance healthy. So we will have questions, I think, in a little bit.
Val, thank you so much. That was wonderful. Wonderful talk on nutrition and all the information to optimize health in our dancers. Appreciate that very much. I do want to encourage everybody, if you have questions, please submit those through the Q&A. After our next speakers, we'll have a few minutes to answer some questions along with a little bit of a break. So if you do have particular questions, please do submit those. And it is a pleasure to introduce our next speakers. So our next talk is going to be given by 2 speakers. So Dr. Mandy Blackman received her Bachelor's of Science in Education in Exercise and Sports Science from the University of Georgia in 2002, and her Doctor of Physical Therapy from Emory in 2005. Dr. Blackman is a board-certified specialist in orthopedic physical therapy with 16 years of clinical experience treating patients with musculoskeletal conditions. She specializes in treating performing artists and dancers and is the head physical therapist for Atlanta Ballet. Mandy owns a private practice in Atlanta and is a managing partner for Atlanta Dance Medicine in Roswell. Dr. Blackman is adjunct faculty in the Doctor of Physical Therapy program at Mercer University in Atlanta, Georgia. Her current research areas of interest include hypermobility, relative energy deficiency in sports, trigger points in dry needling, and injury surveillance and prevention in dancers and performing artists. She speaks on these topics at local, state, national, and international meetings. She is also an instructor for myopain seminars in the Janet Travell Dry Needling Training Program. She was certified in 2010 and has been teaching since 2013. She is involved in leadership of multiple performing arts medicine organizations, including Performing Arts Special Interest Group and Dance USA's Task Force on Dancer Health. Dr. Emma Faulkner attended Elon University, graduating in 2012 with a Bachelor of Science in Exercise and Sports Science with minors in dance performance and choreography and public health. She attended Emory University, where she graduated in 2015 with her Doctorate of Physical Therapy. In 2017, she completed Mercer University's residency in orthopedic physical therapy and became a board-certified orthopedic clinical specialist in 2018. Professionally, Emma is a leading dance physical therapist in the Atlanta area and is one of 2 primary physical therapists for the company dancers of Atlanta Ballet. Emma provides PT services for many smaller contemporary and modern dance companies within the Atlanta dance community. Emma is a partner in Atlanta Dance Medicine and provides injury prevention workshops, wellness programs, and performance enhancement services to dancers throughout the Southeast. Emma is also a member of the International Association of Dance Medicine and Science and has presented many times at their annual meeting in the US and abroad. Dr. Blackman and Faulkner are going to be speaking this morning on hypermobility in the dancer. Thank you for being here this morning.
Thanks, Dr. Gleason. We're excited to be here. Emma's going to share her screen and I'll get us started. Bottom right, Em. There you go.
Oh, that's the wrong one. Hold on. This one.
Yeah.
There we go. Perfect.
Awesome. You can go on to the next slide. This is a lot for me, y'all. I'm in control. So we know that hypermobility is very common in many of the athletes we see as physicians, physical therapists, athletic trainers, dietitians, and it really can be celebrated among a number of different types of athletes, including what you see here, circus athletes, gymnasts, divers. But for our purposes today, we're really going to speak specifically to the dancer. We see hypermobility very frequently in the dance population. And the question always is, are these self-selected or is dance causing hypermobility? And we're really not sure. Are hypermobile dancers born or are they made? One study from 2011 found hypermobility, especially in students, as high as 44%. And then another one of our colleagues, Maura McCormick, found actually a higher prevalence in younger dancers and students than in professionals. So it's curious to think about, why is this happening? Are these dancers self-selected for their hypermobility earlier? But then does that hypermobility actually become a detriment later on as they try to move toward more of a professional career? So hypermobility can really live along a spectrum. All the way at the far left, you can have a very localized hypermobility that may just be one single joint or just slight hypermobility of generalized or multiple joints, all the way to the far right, where we're really thinking about our Ehlers-Danlos syndromes and full body hypermobility that's affecting multiple connective tissues and different systems throughout the body. So when we're looking at dancers, we're not necessarily putting them specifically along this spectrum, but just keeping in mind that they can live along this spectrum and we can make changes throughout. So what's really going on with our hypermobile dancers are that there's a pathology in the collagen proteins that are going to affect the body systemically. So those collagen proteins are structurally deficient, which is going to affect healing of the tissue and really may present as various genetic mutations throughout the system. When we look at these dancers clinically, there's a lot of conversation in the literature about diagnosis of hypermobile EDS or hypermobility spectrum disorders. You'll hear all of these different terms thrown around. And really the important thing for you all to remember is to base this on a clinical presentation. So many of you are probably familiar with the Beighton score, which you see here. It's a scale from 1 to 9 looking at hypermobility at multiple joints. But there's some newer research coming out just in the last 2 years, really focusing on the fact that the Beighton is not going to be adequate for diagnosing hypermobility spectrum disorder, especially in the dancer, because of its heavy reliance on upper extremity. When our dancers, we see much more issues in lower extremity hypermobility. So I'm not going to get into the large criteria for EDS here. You guys can look that up. There's lots of different pieces that go into a full clinical diagnosis of true EDS. But when you're thinking about just a clinical diagnosis of hypermobility spectrum, we're really going to focus a lot on what we see in that patient that's sitting in front of us. And that's going to be a lot of these things. So Emma and I see so many hypermobility patients that we can kind of spot them from a mile away. But for those of you who may not see as many of these patients, these are some of the things you want to keep in mind. Postural and behavioral presentations. So you'll notice that Emma and I have a lot of trouble sitting still as we sit here and try to present on camera. And you're going to see that in your hypermobile patients as well. A lot of leaning, a lot of shifting in their chair, trying to prop themselves up on different things, very fidgety, forward head posture, leaning. When they're standing, they're often hanging out on their Y ligaments. So just typical postural presentations that you will see when you very first interview your patients. Many of these patients are coming to us in clinic because they do have pain. I'm not going to get into a lot right here in this particular lecture on central sensitization, but it can be a huge factor in our patients with chronic and unresolved pain. So frequently clinicians are giving what's called the central sensitization inventory to our patients with suspected hypermobility, which you can see there. It's a nice outcome tool that's going to ask about a lot of these other clinical presentations that I'll go through here. Emma, can you go back one slide? Thank you. So these dancers will often present with a history of dislocations and subluxations, likely of the same joint over and over. So you'll hear the dancer that says, oh, my shoulder pops out all the time, or my kneecap pops out all the time. Typically, they'll have a history of soft tissue trauma and slow healing, along with overuse injuries. So the Achilles tendonitis and FHL tendinopathy that Dr. Barito was speaking to earlier, we're likely to see these types of presentations in the hypermobile dancers. High levels of fatigue and non-restorative sleep patterns, decreased proprioception, and falls. So these are the patients who run into the coffee table that's been in the same spot in their living room for 3 years. These dancers often can't walk down the street without getting injured because they'll trip or they'll fall off the edge of the sidewalk. So it's amazing that they can be such high-level athletes, but proprioceptive wise, they're very susceptible to traumatic injuries because of their decreased proprioception. And then other systemic issues we might see, similar to what Val was just speaking to, GI issues. So often these dancers have what self-diagnosed IBS or chronic constipation, chronic diarrhea, fluctuating back and forth, food sensitivities that affect their GI, urogynecological issues. Many of them have endometriosis or PCOS, or very, very painful and heavy periods if they don't have those diagnoses. And then just sensitivities in general. So food sensitivities, but also allergies, environmental allergies, sensitivities to light, sound, smells, chemicals, medications. And then often these dancers will also have a history of chronic headache or migraine.
So now we're really going to start talking about the hypermobile dancer. So Mandy gave us kind of an overview of what the hypermobile patient will look like. And so I'm going to dig a little deeper into the actual hypermobility presentation in the dancer. So the hypermobile dancer can exist anywhere along that spectrum from a few slides before, from having one hypermobile joint all the way to having full-blown hypermobile EDS. In the younger dancer, a lot of times their activity levels and the strengthening and all of the training that they do is protective. And so they may not have as many pain complaints or dislocations, subluxations when they're younger and performing at a really high level. That may show up a bit later. And hypermobility is often encouraged in the dancer. So like the bendy kid is the one that the teacher's gonna be like, oh my goodness, your extension is so great. Like, let's keep stretching you and make it even better. When in reality, that dancer may not need to be stretching at all. And that may cause more damage or more issues later on in their career, later on in their life. And so a single injury in these younger kids that are dancing could cause this sort of cascade of events that can end a career or cause more issues and more systemic problems rather than just, let's say, an ankle sprain. So I'm going to talk a little bit about the musculoskeletal effects. So a lot of these things are very interesting and kids think they're cool, but these party tricks are not safe and really should not be encouraged. So the cervical spine often has dysfunction in conjunction with the jaw, in conjunction with thoracic spine, in conjunction with the shoulder. One of the most sort of dangerous things that we really want to rule out in a hypermobile dancer with neck pain is AA instability. So that upper cervical instability that can cause issues with more neurologic problems and even issues with the spinal cord. We often see these patients having the chronic headaches, the migraines, the tension type headaches, and the cervicogenic headaches that are just coming from those muscles in their cervical spine, having to work twice as hard to help stabilize those hypermobile vertebrae. And we also see earlier onset of arthritis through the cervical spine in these patients. So the shoulder, multidirectional instability is a really common one. So oftentimes if you have an acute dislocation in, let's say, a football player, they may have anterior instability in that shoulder or inferior instability in that shoulder, which could be corrected surgically or, treated with PT. But in the hypermobile patient, oftentimes it's going to be multi-directional. So you'll have anterior instability, you'll have subluxations that also go posterior, and that's a little bit more challenging to treat. We'll often see the winging scapula just because poor motor control is really common. Proprioception is not great in these dancers, and so they don't often know where their body is in space. So then they have an even harder time understanding, where is my scapula? Where is my shoulder blade sitting on my rib cage? Where is that supposed to be? So they have trouble controlling that scapula. The shoulder is the most commonly dislocated or subluxed joint in these patients. The other most common one is going to be the knee. But with the shoulder, we already know it has the most mobility of any joint in our body. So with that excess mobility naturally comes the risk for instability. And then you double down on your excess mobility in these hypermobile patients, and you're setting them up for subluxations and dislocations. And sometimes we can get a brachial plexus injury or some other nerve injury in these dislocations, especially if they're repeated or the first one is more traumatic. We also can see some developmental dysplasias at the shoulder and also at the hip in these patients. So elbow, wrist, and hand. So hyperextension injuries of the elbow are going to be pretty common. Sometimes we'll see dislocations. One thing that you'll often see in younger hypermobile patients is very poor handwriting, delayed fine motor control. So if you're interviewing a younger patient and their parent, that may be a good question to ask. Did they draw late, or is their handwriting pretty poor, or do they get really fatigued at the end of the day? And you notice a sharp decline in their ability to write or draw at age appropriate levels. We can see finger dislocations, all the nerve compressions at the carpal tunnel, cubital tunnel, all of those places throughout the upper extremity. We can see nerve compressions. Raynaud's is also common. And then again, because those muscles are really struggling to support hypermobile joints, oftentimes the handshake is going to be very weak due to poor grip strength. So thoracic spine and rib cage is not something that we really think about all that often. In treating dancers, we think, oh yeah, lower extremity or maybe upper extremity for lifting. But in the hypermobile dancer, we actually see quite a bit of dysfunction at the thoracic spine and at the ribs. So rib slipping or subluxations of the rib at the costovertebral joint or the sternocostal joint can actually be fairly common. Costochondritis or just rib pain is common. We can see thoracic outlet syndromes, and oftentimes these dancers will present with a slight increase in kyphosis, again, because those muscles are working really hard to hold them up into a really good upright posture. These dancers can also have scoliosis, just like anyone in the normal population, but oftentimes we'll see that scoliosis increase with fatigue. It'll present more into that functional scoliosis as those muscles get tired from trying to support the joints. And another thing we see here is more autonomic dysfunction. So our autonomic nervous system lives near our thoracic spine. And so a lot of times these dancers will have an overactive sympathetic nervous system. So they'll kind of be stuck in that fight or flight response in their bodies. And so addressing some thoracic spine dysfunction can oftentimes help downregulate the sympathetic nervous system. So lumbar spine and pelvis. Chronic pelvic pain is common. We see lumbar instabilities, we'll see spondylolisthesis, we'll see any other spondylopathies where the joints and the vertebrae in the lumbar spine are sort of shifting and slipping around because they, again, don't have that good muscular support. And those muscles, again, get fatigued really easily and have trouble controlling those hypermobile joints. Oftentimes too, we'll see sort of functional pelvic obliquities where muscles easily pull the pelvis into odd positions. So we'll see, innominates rotated anteriorly, which may give the dancer the appearance of having a leg length discrepancy when really it's a muscular imbalance from them trying to compensate and hold themselves stable. Good news is, if you're a physical therapist or an osteopath, oftentimes those dancers correct really easily and we can get them back into a really nice position. Muscles will be working properly. Bad news is they oftentimes go right back into their pattern of muscle holding, gripping for stability. So it's kind of this give and take of, correcting alignments and getting them in good positions and then them slipping back out and correcting and slipping and correcting and slipping. So when I talk about PT treatments in a little bit, we'll talk about ways to manage that. Hip and knee. So in dancers, this is a place where we already see issues. So add hypermobility to that and we'll have even more issues. So we can see the congenital dysplasias, we can see dislocations, snapping hip, very common. All of these are common in any dancer. Recurring patellar dislocations are going to be what we'll see more often in the hypermobile dancer. Very common to have patellofemoral joint syndromes, patellofemoral issues, tracking issues, stuff like that, where muscles are pulling, holding, trying to get stability, but may not be doing it in the most efficient way possible. We'll also see ACL tears in these dancers too. Issues in the posterior knee due to locking out into that hypermobility like you can see in the picture. And then we'll often see different malalignments, so hips that are retroverted, hips that are anteverted, and working with dancers with both of those types of alignments is really important so that they know how to work within their own skeletal structure. So foot and ankle, we've heard a good bit about this morning from Dr. Berto. So some things that we see here are going to be very flat feet, where again, muscles are not giving the support to the joints in the foot. Ankle instability, chronic ankle sprains, plantar fasciitis, bunions, other deformities like that we'll see very frequently. And then with hypermobile dancers and hypermobile patients, people in general, we'll see earlier onset of arthritis just because we'll have increased joint motion and increased load through those joints. So oftentimes we'll have hip arthritis, knee arthritis, and in the dancer, we'll see arthritis of the great toe, and that will come on a lot earlier and often present more severely.
So as I mentioned earlier, a lot of times when we're interviewing these patients right off the bat, we see that there are other systemic effects going on, especially in our dancers or patients who might be further on the right side of that hypermobility spectrum that we showed. So either a generalized hypermobility disorder or even Ehlers-Danlos syndrome, because it really can affect every single system. The problem we see is that often these patients nor their healthcare practitioners realize that all of these things are related to an underlying hypermobility. So these patients might be seeking out care from lots of different people for different symptoms, and nobody's really putting it together. So you can see some of those here. They might be seeing Dr. Gleason for frequent strains and sprains, or they might be seeing Dr. Berto for a more orthopedic surgical concern. They might be going to a neurologist for dysautonomia type symptoms, migraines, and even POTS, which is postural orthostatic tachycardia syndrome, which we're not going to get into a bunch here, but patients who are having blood pressure and heart rate regulation issues. They might be seeing Val for symptoms of disordered eating, eating disorder, or energy availability. A lot of these dancers are also presenting with depression or anxiety or symptoms of OCD, so they might be seeing a counseling professional. Primary care for sleep deficiency or fatigue. They'll be seeking out thyroid testing to figure out why they're so tired and why their sleep isn't restorative. They might be seeing gynecology for symptoms of endometriosis and pelvic pain. They might be seeing an allergist or an ENT for asthma, allergies, food sensitivities, mast cell activation syndrome. Again, we're not going to get into that a ton today, but it's fascinating if you're interested in these patients. GI for some of the things that Val mentioned with the stomach pain, chronic constipation, IBS, and food sensitivities. Cardiac may be playing a role. And then they may be ending up in the PT office for pain and to manage some of these different injuries. And I think for a lot of us, that's where we may come in. If you are the healthcare professional, whether it be the athletic trainer or the PT or the physician seeing this patient, these patients are so frustrated because our medical system is so siloed. So they've seen all of these different specialists, but nobody's really put that full picture together and said, hey, you might be dealing with an underlying connective tissue disorder. Let's manage that from the bottom up and the top down to really get you some help systemically.
So Mandy just said, you may be the first one picking up on this. And physical therapists, because we spend so much time with our patients, we often are the ones seeing it first and kind of guiding them toward those different practitioners. So I'm going to quickly just talk on some clinical pearls of physical therapy management. So manual therapy is important in these patients, but something to be cautious of is that oftentimes they love manual therapy, and there is the potential that they get very addicted to some of these passive treatments. So they need to be used sparingly and within your clinical judgment. So releasing extremely tight soft tissues, whether that is with manual stretching, manual trigger point release, or trigger point dry needling, is really helpful and is also going to give them some really good pain relief in the short term. We can also do nerve mobilizations if they're having any of those nerve entrapments, or if the muscles are just getting really tight around some of those nerve pathways. We want to be cautious with joint mobilizations and probably will not be going into sort of your grade 3s and 4s, some of those higher level mobility increasing joint mobilizations. And then the note on stretching, a lot of times these patients want to be stretched. They feel like they need to stretch. They come in and they fold over into a complete forward fold and say, oh my gosh, my hamstrings are so tight. Really, education is important here, and in teaching them the appropriate way to stretch and how to stretch safely. Stability is a huge thing for these dancers. So we really want to increase their ability to stabilize their joints. We want to increase their proprioception, and we really want to improve their balance. So these are some really cool stabilization treatment ideas. If you have access to red cord or some of the Pilates equipment, that is a really good way to teach these dancers how to activate their core appropriately and activate some of those deeper stabilizer muscles. You also can utilize something as simple as a TheraBand that you may have in your clinic to help provide some proprioceptive input to those weakened or less stable joints so that the muscles can activate appropriately. So proprioception, we really want to help them with localized joint awareness if they've had an injury to a certain joint. So for example, they sprained their right ankle. We do really want to focus on proprioception at that ankle, but they also need help on overall spatial awareness. So if you're working proprioception with a hypermobile dancer, don't get too narrowed into the joint that is affected. Really focus on their ability to just walk across the room safely, because like Mandy said, these are the folks that will run into something that's been in their house for 10 years in the exact same place. So some proprioception and balance treatment ideas, we can use whole body vibration, which is some really interesting, there's some really interesting research out there on hypermobility and whole body vibration, if you're interested in that, helping to kind of improve their proprioceptive sense using vibratory input. We can also use visual cueing. So the girl in the mirror there is using her visual system to assist with putting her body into the correct placement. We can use PNF techniques. We can use taping to help provide some proprioceptive input to the body. So those are just some really easy, cool things that we can do for proprioception. For balance, which again is tied in with proprioception, we really want to make sure that we're putting function first. So static balance on point on a Bosu ball is a really cool Instagram story, but it's not exactly functional for what these dancers need to be able to do. Like very rarely are dancers going to be dancing on a stage that is made out of foam or squishy or anything like that. So making sure that we're teaching them how to balance and move through their positions and move through their dance movements that are required is going to be really, really important rather than just looking cool. Some other things that we use with these patients are going to be external taping and external bracing, because oftentimes the internal system just isn't functioning quite up to par. And while we're training them and working neuromotor control and working proprioceptive training and stability training, we can utilize some of these other external tools just to assist the muscles in finding where they are in space and stabilizing those joints. So compression garments are really good. Ring splints are helpful for fingers, and a lot of taping and orthotics.
So we also often need to address these patients from more of a chronic pain standpoint, looking at central sensitization and sort of down regulating their autonomic and sympathetic responses that we often see heightened in these dancers. So again, we could do a whole weekend course just on this, but we might use tools like Emma mentioned earlier, starting at the thoracic spine. We might need to treat contralaterally before we can go into a joint that might be more CPRS or really activated and hypersensitive. We can use graded motor imagery, mirror box therapy, lots of ways to desensitize these dancers. If they get to this point, our goal would be to catch these dancers before they become centrally sensitized, which if you're looking for hypermobility may help you catch them sooner. We also have to think about the medical management. A lot of time alternative therapies are great for these patients. We might be using things like Dr. Barreto mentioned with PRP or stem cell or even prolotherapy injections to help try to stabilize a certain joint. These are going to be preferable to corticosteroid injections. If a dancer does have to have surgery, we want to consider some of those surgical implications because often that tissue is poorly healing or slower to heal. These dancers also have to have the atypical response to anesthesia. They may need a lot more anesthesia than the average patient of their heart height and weight. And then also thinking about pharmacology in these patients. So there's a lot of good research out there about opioids. If the dancer has mast cell activation syndrome, opioids can actually exacerbate their pain and make them worse. So we really want to think pharmacologically about some other options for pain management. Things like low dose naltrexone, ketamine, cannabinoids even are being often used in this patient population with more success than your traditional opioids. Frequently, you also need an antidepressant in conjunction with some pain management. So things like Cymbalta, Effexor can really help to decrease pain management and address some of those other psychological concerns we talked about earlier. And then pregabalins, things like Lyrica or gabapentin can also be very helpful for neuropathic pain. And then with nutrition interventions, again, like Val mentioned earlier, there's no one size fits all. Please, if you hear a dancer who says, oh my gosh, I think that all dancers need to be on XYZ diet, please refer them to Val. But we do know in our dancers who have hypermobility and high levels of chronic pain that we may need to play a little bit with their nutrition, looking at food sensitivities or anti-inflammatory type interventions, and maybe some probiotics or supplements, but trying to really address with whole foods first. We also see that the hypermobility we see in these dancers may lead to early retirement. So the biggest thing we can encourage them early on is to stay active and keep moving. We know that motion is lotion and can really help these dancers stay functional and stay healthy longer. A lot of times we don't start seeing issues in the dancers until they retire and really stop moving. So this is going to be a big piece for education when you're treating this population. A lot of different resources here. There's Ehlers-Danlos Society and different hypermobility groups. Finding practitioners that are interested in working with this population so that we can treat collectively is going to be very important. And then we put a couple of books up for you here. That one on the bottom right just came out in the last year. It was written by probably 30 of our colleagues, medical and allied health professionals. And I have to say, I think it's probably the best book on the market now for both healthcare practitioners and patients who are dealing with any kind of spectrum hypermobility disorder. It's got some really good information on mast cell activation syndrome and some other things that we mentioned today if you want to delve deeper into this topic. Those are our references. And I know we're a little over time, but I think it's question time, right, Courtney?
Yes, thank you so much. That was so informative and wonderful. Thank you very much on that talk on hypermobility and really all of the implications associated with that. I think it's so educational for everybody to learn more about that topic. We are going to take a few minutes for question and answers, and then that'll leave us a few minutes for a break. So we will start with this question from one of our audience members. Can you do a manipulation to a hypermobile patient to downregulate the sympathetic system and also to assess for referral of pain and central sensitization? Also, do you find most ballet dancers have pain at L5, QL, lumbar multifidus, contributing to poor motor control or the posterior, poor motor control of the posterior chain?
Emily, you want to take that one?
Sure. So yes, you can manipulate a hypermobile patient. You just have to do it cautiously and really use your clinical judgment and make sure that that patient is truly a candidate for it. Probably the most manipulated area on a hypermobile patient is the thoracic spine. And absolutely, that is going to help to downregulate the sympathetic nervous system. And a lot of times, hypermobile dancers, they hold all of their tension and they kind of hold themselves up with their thoracic spine. So in addition to down regulating the sympathetic nervous system, you'll get some really good short-term pain relief there too. And then, yeah, I do see a lot of dysfunction at L5S1 and dysfunction at the QL. And it does correlate with poor motor control of that lumbopelvic region. And then oftentimes think what ballet dancers especially have to do with extending their leg behind them in arabesque and back attitude. What are they going to utilize? They're going to use QL and they're going to hinge at that L5S1 or at TL junction. And so, yes, absolutely, we see dysfunction there. And that is a great place to start your motor control and motor retraining, is getting some better lumbopelvic control so that they can utilize bigger muscle groups, glutes, in addition to QL without hinging at some of those spots.
I would say, I would add to that, that often we see that dysfunction on their more preferred stance leg rather than their gesture leg. And remember, the trigger points in the QL can also inhibit the glute. So it's sort of this vicious cycle where they're just relying on QL over and over and can't activate that posterior chain.
Thank you. And then there's a follow-up to that question. Are you guys able to see that in the Q&A, or you want me to read it out? It's up at the top. I can read it. So the follow-up to that is, also, I find that the dancers treated seem to have increased difficulty and pain when training in normal functional positions versus ballet positions. While turned out, they gain more ankle joint mobilization versus a neutral. Do you find that some pain that dancers have is due to overuse of their ballet position versus normal positions? And in that case, would you train in a normal versus ballet-based performance schedule?
Yeah, so I'm sorry. I tell every single one of my dancers that whether they like it or not, they're a normal person first and then a dancer. So I absolutely train them outside of dance positions because you're right, that is where a lot of times they'll have more dysfunction and more pain. And so I am all about putting a dancer, especially a ballet dancer, in parallel and really making them work there, whether I put them on the reformer to do that or I have them in weight bearing doing that. Because yes, absolutely, that is what we see.
And a lot of times these dancers do have retroverted hips, so they're just sitting in a more externally rotated position anyway. So that is their position of comfort, but we have to make sure that they're balanced.
Thank you. Speaking about hips, any tips for hip dysplasia in terms of new diagnosis?
That's a hard one. So it kind of depends on the, hi Susan, degree of hip dysplasia we're talking about. How much is that acetabulum actually covering the femoral head? And does it have enough bony stability that we can uptrain the muscular and ligamentous components around it to maintain some stability? Or are they dislocating all the time? So it's going to be dependent on the degree and the severity, I would say. Emma, do you want to add to that?
No, I mean, that is exactly it, is how much muscular control can we get around that joint. If we're not able to get muscular control around that joint, then we're absolutely going to have to go for a different treatment approach, probably more invasive.
Thank you. Is there a better style of dance that is better for a hypermobile dancer?
I'm gonna throw a personal thing out there. So I am a hypermobile dancer, and I actually did find that modern dance and contemporary dance was a little bit more suited to my body, just because it's a bit less rigid than classical ballet, and oftentimes you are training in different positions, including parallel, including deep plie, very grounded movement. So personally, I found that more helpful, but that is very dancer dependent. Some dancers can do great in classical ballet if they train their body properly, and especially from an early age.
And it'll depend on their artistic director or their teacher demands as well. And if their choreography is set to suit their hypermobility or support it versus working against it.
Thank you. That's very helpful. And then we have another question that was submitted. This attendee asks, I have a dance student that fractured some of her ribs with partnering in December, and she's had pain since then, but didn't have a doctor look at it till recently. Suggestions for exercise and rehab for this type of injury. She's got poor tolerance to modern technique class right now. She's wearing a back brace per her physician order to protect the area during dance.
My gut is mobilize, mobilize, mobilize. So as long as those ribs are healed, I would start looking at mobility of the thoracic spine itself, but also the soft tissue and fascia around that area. So it's likely that inflammation and immobility has caused restriction in that fascia, and you may need to get in there and do skin rolling or some cupping to really get that area moving. Dry needling, if you're trained in it, around the multifidi of the levels of those ribs that were injured. Emma, you want to?
The other thing I would say is just really look at their breathing patterns and make sure that they have symmetric rib expansion. They're getting that 3-dimensional rib expansion, because a lot of times they will protect that side and sort of self-splint that side and won't get good active mobility during breathing, because dancers work hard and they have to breathe heavily. And especially in modern technique, where she's doing probably a lot of side bending and twisting and stuff like that, she really needs to be able to move those ribs 3-dimensionally. And then I'd also just check on the diaphragm and see if that had become a little sticky or a little impaired during the healing process.
Perfect, thank you. And we'll do one last question, and then we'll just take a 5-minute break, let everybody get a quick breather, and then we'll come back and start the second session, but this has been wonderful. Really great that there's so much audience participation. So thank you. Please continue sending your questions to us. So our last question for right now is, do you see more hypermobility in pre-pros or professionals? And what do you see as the most important prognostic indicators in pre-pros?
Hi, Dr. Gleason. I would say we see hypermobility in both. I know Maura McCormick's research study really indicated that there was more hypermobility at the student level. And I think that can be true depending on which patient population you see. But as PTs, I think we're getting those dancers who are injured. So we probably see a higher level of hypermobility that is actually out there, just anecdotally. And as far as prognostic indicators, I would say strength and stability. So if we can get their technique really good and work on injury prevention and proprioception early in their training, to me, that's going to only bode for better outcomes later on. Emma, what would you say?
The other big thing that I see with the like sort of pre-pros is the ones that had training very early in their career that was protective and conducive to their hypermobility, they tend to do better. The ones that were celebrated for being bendy and overstretched and all that sort of stuff early may have more trouble transitioning from that pre-pro level to the pro level.
I agree.
Wonderful, thank you. All right, well, let's take a brief break. Let's reconvene here at, we'll just say at, what time is it now? It is 9:44, so why don't we say 9:50, we'll reconvene. I am gonna put up just a little slide on Atlanta Dance Medicine, which is the physical therapy group in Atlanta, comprised of 7 or 8 physical therapists that Dr. Blackman and Dr. Faulkner have started, and our next speaker, Dr. McDougall, is also a part of. So I just want to put that slide up just to give you a little bit more information on that, and we will reconvene in about 5 minutes. All right, we are going to get going again. Just been such a great morning so far with great talks and great participation from all of you who are here. And I see that there have been a couple other questions, so we will definitely get to those at the end of the next 4 talks. So our next speaker is going to be Dr. Ann McDougall. Dr. McDougall received her Bachelor of Science in Biology with a minor in dance at the University of Georgia in 2012. She earned her Doctorate of Physical Therapy from Mercer University in 2018. As a classically trained ballet dancer for 21 years, Dr. McDougall has a passion for performing arts and dance medicine with a vast understanding of dance technique, dance-related injuries, and dance-specific rehabilitation. Dr. McDougall serves as a clinical director at Atlanta Dance Medicine and as an adjunct therapist for the Atlanta Ballet professional company members, as well as a staff physical therapist at Team Rehabilitation Physical Therapy in Midtown. She is a certified myofascial trigger point therapist through Myo Pain Seminars, where she's certified in trigger point dry needling. Her clinical specialties include manual therapy, dry needling, myofascial release, return to sports rehabilitation, performance enhancement, and wellness injury prevention. Dr. McDougall is a member of the International Association of Dance Medicine and Science, and she's going to speak with us today on a variety of physical therapy techniques for the dancers.
Thanks so much, Courtney. Let me share my screen. Okay. All right. Well, thank you so much for the intro and good morning, everyone. My name is Ann McDougall. I am a physical therapist. Alongside Mandy and Emma, I am serving as the clinical director for Atlanta Dance Medicine. I also work with the Atlanta Ballet professional dancers, as well as treat all types of orthopedic patients at Team Rehabilitation in Midtown, both dancer and non-dancer. So today we're going to talk about the basics of PT for dancers. And there's a lot of information that's going to come today. It was kind of hard to put this all in a quick, 20-minute presentation because there's so many things that we think about. But I want you to, as we're going through this, the kind of flow that we're going to, that I have set up for this is just to think about how we manage the dancer client and the type of demands that are unique to them, how that changes our clinical exam and our treatment approach, and then thinking beyond the injury in terms of injury prevention, all the facets that we have to think about and that have been discussed already today that really make this type of client unique and different from your kind of typical orthopedic patient. All right, so treating the dancer. How do we compare professional dancers to a professional competitive athlete in a competitive sport? So this might come as kind of obvious, but there's different movement patterns. So especially if we're talking about classical ballet technique and what we saw with Jennifer in her lecture with terminology, we're standing in turned out positions the whole time. We are moving and the positions of function there are very different than being in parallel. So how does that produce pain? How does that cause these overuse injuries? We have to be thinking about the type of demand that has. Another thing to consider too is that competition is a little bit different within professional dancers. So it's largely with oneself. It's an individual sport. There of course can be competition for roles or getting into certain programs alongside other colleagues, but it's very artistic in nature. And so these dancers kind of a lot of times have that perfectionist mentality where the competition is with themselves, but they can be very, very hard on themselves. So we may have some psychosocial factors that come in with that, and that may be contributing to their pain as well. Along with that is the need for a sense of approval. So whether or not you've been working with an instructor for 13 years who's been teaching you this whole time as an adolescent dancer, or if you're in a professional company and they are bringing in a international choreographer who's coming in to set an amazing piece, you want to be picked for that role. And that can add a lot of extra stress on these dancers. As we talked about before, there are several forms of dance. Largely, this lecture is going to be focused on the classical ballet technique, but just remembering who's sitting in front of you and whether or not they're a ballet dancer, a modern dancer, or hip hop, or Irish, or Broadway in character, or if they do a multitude of those things, making sure that we're asking the right questions to really understand the demands that they're dealing with every single day. And then what are the commonalities between these dance forms? So the risk factors involved, there's going to be several that we're going to go through today that are really important for us to consider. Some of them can be changed and modified, and a lot of them cannot. So that's going to be another contributing factor to not only their injury, but how we actually can rehab them. Obviously, we're going to see extremes of joint movement. And a lot of times being in those end range movements and having to have stability there is very difficult. So we're looking at the overuse of those joints and being conscious of breakdown of the tissue if we're not really looking at the technique properly or having them be aware of what they're doing. Another thing that we're going to see is, especially what's going to drive injury, is repetitive forces and microtrauma on those joints. This is something that they can't really get away from based on the type of technique that they have to be or the position they have to be on. So making sure that we're trying to educate these patients about what it means to be doing that every single day and how to keep those joints and those muscles and tendons and ligaments healthy. And then of course, dance forms will all have certain artistic and choreographic demands that can be ever changing depending on the type of choreography they have to do for one piece versus another, and what that means as well for injury. So considerations regarding injury, just making mention of the difference between acute injury and chronic injury and what we see the most of. So an acute injury like your lateral ankle sprain or your fracture or ACL tear that could come from a fall or turning wrong on a point shoe is going to be less common, but we do see it, versus our chronic injury, that overuse, the microtrauma to the tissue, is the most common. And so we heard a lot from Dr. Barito today, especially within the foot and ankle, about tendonitis or tendinosis of the Achilles tendon or the flexor hallucis longus. And these are just overused foot and ankle muscles that we're constantly seeing and constantly having to treat. A lot of times we're going to be looking mostly and hoping for mostly conservative treatment, but there is that small percentage that may require surgical intervention where we'll be treating them post-op as well. So some of those risk factors and variables that come into play. So our intrinsic risk factors that we have, some of the things we cannot change. So a dancer's age or gender, weight, their actual anatomy and their musculoskeletal system, talking about their nutritional status, their personality type, any other past injuries they've had. Are they a hypermobile, and how hypermobile are they? Are we looking at a spectrum, one of the spectrum disorders? Are we looking at Ehlers-Danlos? And then any faulty mechanics that are being driven from all of these. Some extrinsic factors that are always into play are the type of choreography, the teaching style, depending on your instructor, the flooring, the lighting, the costumes, footwear, depending on the type of dance. One thing that has been particularly interesting within the COVID-19 pandemic is a lot of dancers have had to not be in studio and purely dance from home on Zoom, and they're not dancing on proper flooring. There's not, the spring isn't there in the floor for jumping. They may not be on Marley. And we've seen a lot of orthopedic issues that have come about just from the fact that they spent, 3 to 5 months at home doing Zoom classes. Thinking about adolescence, this is a really broad topic, but I just wanted to make mention, remembering who you're looking at in front of you when they're talking and asking the parent or the patient, did they have a recent growth spurt? Are they in one right now? Is that going to be something that's affecting their pain pattern as well? Not forgetting the female athlete triad. The three the three components of this are talking about the relative energy deficiency, like we talked about in Val's lecture. Is there any issues with menstrual dysfunction or amenorrhea? Also, what about decreased bone mineral density, and whether or not we're looking at an issue that's going to turn into something like osteoporosis? And then, of course, considering the relative energy deficiency in sport that can happen in both males and females. Another factor that I think is really important for the psychosocial aspect is the worry that some dancers can have of seeking healthcare and seeking people like us that know about the demands of their sport and their art form. And a lot of times there can be a huge fear component with that. So fear of being taken out of dance, fear of being told you can't dance in that principal role that you were just given, How about financial hardships? You know, professional dancers are not known to be, they're not in their sport or in their art form because it makes them a ton of money. They do it because they love it, but it's very hard to be able to allocate their funds to expensive healthcare. And then, of course, what's great about today is that we're talking with a lot of healthcare providers who do know about dancers, is trying to educate other healthcare providers who may have a lack of knowledge about dance. And sometimes the notion of telling a dancer that pain is normal can be really detrimental to the psyche of the dancer as well, because that's not always the case. No pain, no gain is really not always what we're going to be using. And it's important that we are actually really taking the time to educate dancers about their body, how they're using the body, and how to keep it safe. All right, so some range of motion demands. This picture is a great one to see that we actually, in classical ballet technique, need 180 degrees of what we call turnout. So that's at the femoral acetabular joint, that's at the hip joint. The knee must follow, and the ankle as follows as well into the foot. So you're seeing that this dancer is completely externally rotated at the hip. Her knee is right over that second toe, and this is her in a grand plie position. The other thing, and I have a great picture on the next slide, is a lot of that hyperextension that is needed at the tibiofemoral joint. So now we're not necessarily talking about someone who is so hypermobile that we're getting into real instability, but there needs to be greater than 0 degrees at the knee joint in order to do some of the motions within the ballet technique. Of course, we want to see increased ankle mobility, so that talocrural joint. So that's going to be really important, and it needs to be in both directions. So plantar flexion is going to allow for a demi-point, as you see in the second picture. It's going to allow for releve all the way onto point, and dorsiflexion is going to allow that plie position and allow jumps. So a lot of times patients or dancers will say to us, oh, my ankle feels so locked up and it's only when I go up onto releve. So we're going to be doing joint mobilization and teaching them how to do those as well in order for them to be able to not feel so locked in that position. Another one, and as you can see in the second picture, we want to see 90 degrees or more of great toe dorsiflexion at the first MTP joint. We only need 60 degrees to successfully perform gait, but we need 90 or more to actually be up on that releve position. All right, so what do we see with when we're trying to achieve these positions? What kind of faulty mechanics do we see? So in the first picture, because we're trying to have that 180 degrees of turnout, what we're seeing in this dancer is that she's actually forcing turnout. It's not actually coming from the external rotation of the hip. You can see that because as well, the knees are facing forward. A lot of that turnout is trying to actually happen from the feet, and that's actually resulting in a torsional force on the tibia. This can be really, really detrimental and dangerous as a dancer keeps doing this, because you're putting yourself and setting yourself up for injuries at the knee, especially at the medial aspect of the knee. If this picture was in motion, you would see how when that dancer plies, the knee joint is not going to be going over the toes. It's actually going to be coming more so forward. The next picture is subtalar overpronation. So again, with all of these, we have to be considering, are we looking at a musculoskeletal issue? So is it based on anatomy specifically, or is it a neuromotor control issue? So this patient very well could have in a regular standing position, a pes planus foot structure. So there's, and kind of, you can see here a crashing medial longitudinal arch. We want to be teaching in that position how to actually lift up in that arch and see if it's a neuromotor control issue, or do we have more of anatomy that's into play here. For the next picture, for a sickled foot that we call in ballet, you can see when this dancer is in the tendu position, that foot is sort of inverted in. Again, may be something that's going on neuromuscularly, where they're not as able to feel or have that proprioception to know where the foot placement should be, but that's really dangerous when that dancer would eventually go up on point. If they were to roll off that shoe, there's your lateral ankle sprain. And then anterior pelvic tilt. So this patient particularly, you can see standing in this position is really turning on her back extensors, her erector spinae muscles, and lengthening in that front abdominals, where she's really not setting herself up to be in a stable position or even have that lumbar stability that's important. And creating that fulcrum kind of at that L4, L5, L5S1 joint, which can also lead to a couple different issues that we'll see. Mandy and Emma did an excellent job just before me talking about hypermobility considerations. So I just want this slide to be on here so that you are considering, based on your subjective examination or what that patient is saying to you, is this someone that's actually has a little bit more than your average mobile dancer? So utilizing the Beighton score as at least a first pass. And then I have a couple different resources on here, like Mandy and Emma mentioned, like the Ehlers-Danlos Society, for you to kind of dive further in. So trying to figure out, is this dancer somewhere on that spectrum? There's 14 types of these syndromes that can be classified based on the criteria. So it just may be something you want to dive in a little bit deeper to. I know she's on and listening today, but I was introduced via Mandy and Emma, to Dr. Linda Bluestein, and she's a specialist in treating hypermobility disorders. So she has a great website and a great podcast if you want any further information, just to be able to learn more and be a little bit more educated with how you can speak and talk with these patients. Okay, so let's go into some common dance injuries. I did want to make note, this was the slide with this picture where you can see a great amount of tibiofemoral hyperextension. It's a beautiful look, but that's a lot of range of motion that you're seeing as she's standing in that position. So a lot of these injuries have already been covered today, but thinking about, we're going to see a lot of injuries at the foot and ankle, your lateral ankle sprain, your posterior or anterior impingement, trying to figure out if that's a bony or a soft tissue issue. Like Dr. Barreto said, certain fractures that are common at the 5th metatarsal or 2nd metatarsal, bunions, hallux rigidus, sesamoiditis, those two little bones that are there underneath the great toe on the plantar aspect of whether or not those are getting inflamed, especially for being up in a releve position, jumping. And then any type of tendonitis issues that we're going to see in some common muscles that are always being used for pointing and flexing. At the knee, patellofemoral pain syndrome, anterior knee pain, any strains of the muscles, any tendonitis at the patellar tendon, tibial stress fractures. If you are treating or working with a patient that did have this Osgood-Schlatters as an adolescent diagnosis, so always something to consider as well. And then, of course, the torsional forces that happen that could be implicating our meniscus, MCL, ACL sprains or tears, or even especially the load-bearing area of the knee of osteoarthritis. The hip joint, so snapping hip syndrome, being able to figure out if this is an external issue or an internal issue just based on the descriptors that they're giving, any labral issues, any hip flexor tendonitis, and deciding which muscle specifically are they using that's getting overused, are they under recruiting some of the other hip flexors, and then of course a femoral stress fracture, piriformis syndrome, and OA as well. The spine, so this picture as well is beautiful, but she is really, really bent over in that extension position. So we would expect some back pain potentially, or spondylolysis or spondylolisthesis, that anterior slippage of the spine, kissing spine, where there's approximation of those vertebrae and whether or not that's going to implicate on the interspinous ligaments. Any disc herniations, radiculopathy that can come into play, and of course, lots about the SI joint and the dysfunction that can happen at the sacrum and into the pelvis, any pelvic obliquities, all that kind of stuff. Going into the shoulder and elbow and wrist, especially thinking about this with our male dancers that are having to partner. Any instability in the shoulder, like Emma was mentioning, it can be multi-directional. There could be subluxations and dislocations. There can be impingement that happens, rotator cuff tendonitis, AC joint sprain. At the wrist, if there's falls or with partnering, any sprains or strains, and of course at the elbow, another weight-bearing joint or a load-bearing joint when you're in a partnering position with epicondylagel or epicondylitis. I also want to mention that we have all these great diagnoses and they're really easy. Like for example, you could say, oh, this patient's coming in, she's got anterolateral ankle pain, but she didn't actually roll her foot. So are we thinking specifically about am I going to diagnose this as a lateral ankle sprain if there really was no mechanism of injury? Or should I be thinking about the trigger points that could exist in muscles that actually might refer pain directly to that spot? So not forgetting about what's going on in the muscle tissue specifically. And then I have two pictures here on the upper cross syndrome and lower cross syndrome. These are very common patterns of what we see with muscle imbalances. And so which muscles are specifically tight and often chronically tight, therefore being used too much, which ones are weak and are absolutely inhibited. So we see that a lot with the glutes, and we see that a lot with the abdominals and the deep core muscles, but we're seeing, especially with lower cross syndrome, really tight paraspinals and a tight iliopsoas or hip flexor just based on the movement patterns. All right, so after we've taken the subjective exam, we've talked about the chief complaint and past medical history with this dancer. We want to go into our objective exam. And of course, we're going to be looking at their gait patterns. We're going to be looking at their active range of motion, passive, joint mobility, muscle length testing, strength testing. But a huge and really key part of what makes it important and maybe different from a typical orthopedic patient is having that dance specific movement screen. So if I'm going to be assessing a classical ballet dancer, I want to assess those basic positions and the ones that we saw with Jennifer today. I want to be looking at, based on their chief complaint, how they're moving in parallel, how they're moving in first position, going up into releve, doing a couple jumps, going up into a passe position, or anything that I know may implicate their pain or I can reproduce their pain with. And that's where I want to hone in and be looking at these faulty mechanics, if there are any. And then any compensatory mechanisms, any specific muscle imbalances. What am I seeing as being way overused immediately and noticing that what's being inhibited and not being used enough. It's also really important at that time that you're looking at those anatomical features. So you're doing a good screen of whether or not there are any abnormalities. Is this patient anteverted? So that's why she literally cannot get into that 180 degrees of external rotation. Does the dancer have a pes planus foot structure, which is causing that kind of overpronation, even just in standing before you've done any of these specific movements or jumps like that? So Mandy and Emma also covered this a lot too, but just considering all the techniques that we have as therapists for treating these dancers. So going in and honing in on the muscle, because of what we found, we can do myofascial release, instrument-assisted soft tissue mobilization. Are we cupping the area? Are we working on skin rolling? Of course, trigger point dry needling, any muscle energy techniques to take care of those pelvic obliquities that we see, joint mobilization, mobilizing joints that need to be mobilized, being careful of really hypermobile joints, or especially joints that are prone to subluxation or dislocation, and then utilizing our taping techniques. The KT tape, are we using it to facilitate a muscle, or are we going to use it to inhibit a muscle? Using our leuco tape maybe to actually stabilize a joint that needs to be kind of set back into place as we're going through our rehab process. Going into that process, we're always going to be thinking about doing the neuromuscular re-education of the area that is either in pain or is dysfunctional, looking at that motor control retraining, always considering the proprioception and balanced training, especially because we know, and I'm definitely guilty of always hitting my coffee table. That's been there forever. But we're also doing all this within kind of a specialized Pilates and yoga-based rehab. So finding ways to train them that's going to really set them up to get right back to their function as a dancer, and then keep them safe within that, and teaching them this so that they can actually maintain this on their own. And of course, we're going to be setting a dance-specific exercise program that actually has a proper exercise prescription with consideration of a level of acuity and the irritability of the tissue, but also considering who's the dancer that's sitting in front of you. If this is your kind of type A perfectionist that's like, I'll do whatever you want, I will do it, 4 times a day, that may be the person that you're reining back in and saying, okay, I actually want you to only do this once a day, and I want you to do a really good 30 minutes of this. Because dancers, especially when they've got the pressures that they have, they want to get back immediately, and sometimes that can be way too quick, and we really need to kind of rein them in and take that process slow and controlled so that we actually make real changes in the tissue, real changes in the technique, so that we're hoping for prevention of their injury in the future. And of course, considering self-maintenance and management. So establishing a really good warm-up, cool-down program. A lot of with your adolescent dancers, they often may not have this. They may just walk right into class and do a couple ankle rolls and say that they're ready to start bar. Also, what Emma mentioned, proper stretching and understanding the difference between dynamic stretching and static stretching, and not just hanging out in your end range joints and causing weakness kind of at those end ranges. Of course, teaching them soft tissue release, foam rolling, lacrosse ball, massage gun, self joint moves. So if that ankle is stuck, getting them proficient with a TheraBand mobilization or a resistance band so that they can really take this into their own hands and manage on their own. And to bring it all together at the end of what we get to do today, which is amazing, which is the collaboration and coordination of care. So we've figured out the injury, we've treated the injury, we've done the rehab process, but how do I actually think beyond that diagnosis? And it's everything we talked about today. Cross-training. Dancers love, and especially at a younger age, they may really stick to just doing their ballet and modern classes, but exposing them to things that they may not have thought they wanted to train in, or they're fearful of gaining muscle or getting too big or whatever it is. Bringing in swimming and cycling and weight training, that's really going to put them in a different position, maybe like Emma said, out of that turned out position and into parallel, where we're going to train there and get strong there as well, because they often are very weak in those positions. With the impact of COVID-19, considering the aerobic and endurance training, not only because of them having a major decrease in their schedule and maybe not dancing as much as they were when they may have been at 20 to 25 hours a week, and now at home they're just doing a couple Zoom classes a week, but also the mask wear and having to perform on stage with these masks. We don't know how much longer that's going to be, and we have to continue to keep them safe and making sure that they're getting the adequate oxygen. Val did an excellent talk. So a referral to a nutritionist, if you sense anything or think that they would benefit from that, making sure to refer out, because knowing that that's could be a huge contributor to what's going on with their pain or their psychosocial state. Making sure that we're referring to a mental health counselor or stress management because of the psychosocial factors that just exist within the fact that this is their art form, it's their career, and it's also a way that they are making money and being able to be stable. Also just referring to other healthcare providers if it makes sense for their particular injury, a chiropractor, a massage therapist, and then honing in just that early intervention, getting these dancers to come see us sooner. We at Atlanta Dance Medicine work on dancer wellness screens, which is excellent. We do a full scan of the body. We're looking at range of motion, all those faulty mechanics, any compensatory strategies, muscle length, and we find a couple things that we can actually create an exercise program for them just to start. And this may be a dancer that doesn't have any injuries specifically or any pain, but we're just trying to set them up to be successful for their career and to have a long career. And then of course, giving that parent education and dance instructor education as well for that injury prevention, letting that start at an early age. I've been fortunate to join Mandy and Emma at workshops at certain studios where we're giving this type of lecture just to let dancers understand and know how much they really should be thinking about and how to take care of their body, because their body is their tool within this. All right, so I threw up a couple of dance medicine resources as well. These are great sites that have a lot of information that you can follow up with. And then my information, and of course a plug for Atlanta Dance Medicine, follow us on Instagram and Facebook. We are putting a lot of content out and we would love to talk with you guys if you had any questions with us. All right. Thank you so much.
Thank you, Dr. McDougall. That was wonderful. Really informative. Thank you so much. I am, let's see. And I don't know, are you still sharing your screen?
Yeah, there we go.
Okay, perfect.
Yeah.
Perfect. Okay, that's great. Thank you. So I am actually going to give the next talk. I introduced myself at the beginning of the symposium this morning, but I'll just reiterate, I'm Courtney Gleason. I'm a non-operative sports medicine at Emory. I've been at Emory for 4+ years. I did my undergraduate at the University of Notre Dame and then did medical school in South Carolina at the University of South Carolina. I started off in medicine in orthopedic residency in Florida, and transitioned to non-operative and completed a pediatric residency at Emory. I then went up to Boston and did a non-operative sports medicine fellowship at Boston Children's in Boston. And there I worked with the Boston Ballet. After my fellowship, I took a job in Providence at Brown and worked with the Festival Ballet in Rhode Island. And then I've been back at Emory for the last several years and have had the pleasure of working with the ballet and Dr. McDougall and Dr. Blackman and Dr. Faulkner. So I am going to speak today on bone stress injuries, kind of some of the concepts around bone stress injuries in the dancer. And then Dr. Coleman will be speaking. All right, so as I said before, I'm going to speak on bone stress injuries in the dancer. I have no disclosures. I'm going to start with a case presentation. So our dancer is 17 years old. She's a ballet dancer and she presents with right foot pain. She presents 3 weeks into Nutcracker and she reports a 10-day history of right midfoot pain. She initially just noticed pain when she was landing jumps. Now she has pain with walking and point. Pertinent exam findings, she has pain when she walks. She has a slightly antalgic gait. She's not able to do a single leg hop, secondary to pain. She's got some mild visible swelling over the midfoot/forefoot junction, and she's tender over the base of the second metatarsal. So you can see her injury here at the base of the second metatarsal. Here's 1, 2, 3, 4, 5, and she's got a stress fracture at the base of the second metatarsal. So bone stress injuries are common injuries that we see in dancers, and we recognize that bone stress injuries are overuse injuries. So overuse injuries happen because there's an imbalance between training and load to the tissues and recovery time. We know that specifically bone stress injuries are caused by one of two ways. So there's either a repetitive submaximal mechanical stress on normal bone, and that results in a structural fatigue, or it can be caused by normal stress to abnormal bone. So if there's bone that has low bone mineral density, you can get a stress injury with normal types of loading that overloads an abnormal bone. So stress fractures are common in all athletes. Metatarsal stress fractures particularly are seen, they account for about 9% of all stress fractures in athletes in general, but in dancers, even a higher percentage that experience injury in this way. So even prior to skeletal maturity, around 14, 15, 16, about almost 13% of ballet dancers have had a metatarsal stress injury. So that's a large number even before they've kind of gotten well into the adolescent years. In ballet in particular, the second metatarsal stress injury can be a common location. But we do know that with the different types of dance, as Jennifer talked through the different types of dance earlier today, the location of bone stress injuries varies widely depending on the type of dance and location in which the stress accumulates. So kind of knowing the different types of dance and what are more common injuries can be helpful. When we are treating bone stress injuries, we recognize actually that these are complicated injuries and that to treat them and to treat them well and to try and prevent them from recurring, we have to recognize the different factors that contribute. So there are intrinsic risk factors that can predispose a dancer to a bone stress injury, and there are extrinsic risk factors. So we try and take into account and understand all of these to see which ones are playing into each dancer's specific injury. So regarding intrinsic risk factors, things like biomechanics, so things that are intrinsic to the athlete. So biomechanics, sometimes alignment, muscle weaknesses, tightness, sometimes limb length can contribute. Sometimes there's a genetic contribution with low bone mineral density, family history of osteoporosis. And then we also know that there are physiologic states that predispose to bone stress injuries. And Val talked about this, and some of the other speakers have touched on the concept of relative energy deficiency in sports. So we know that a physiologic state in which there's low energy availability predisposes to bone stress injury. I mean, other types of injury too, but certainly this is a major player for bone stress injuries and something that we have to address to really promote optimal healing. And then also a low estrogen state. And that too is interrelated with the concept of the low energy. And we know that estrogen is important for bone health. Some of the extrinsic risk factors for bone stress injuries include sustained excessive hours of dancing. And so, somebody who's dancing, 20, 25 hours a week, sometimes that kind of increases your suspicion of bone stress injury versus somebody who, may have class for 1 or 2 hours a week. Ramping up hours of dance too quickly. So we have seen this very recently with COVID. So studios have been closed and dancers have not been able to kind of continue with their typical normal regimens. And so as the studios reopen and performances are scheduled, then the hours of dance ramp up quickly, and we have seen injuries associated with this. Even if a year and a half ago they would have tolerated this amount of dance, since they're not used to dancing that much, we're seeing injuries. Training surface can have implications as well as technique. So this is the idea of relative energy deficiency in sports that we have talked about already. This is to just highlight that it is important for us to recognize the complex nature of bone stress injuries. The concept of female athlete triad was first recognized within the sports community in the 1990s. And this was really the first time that there was kind of a universal recognition of the interrelatedness between energy availability, hormonal health and menstrual health, and bone health, and that a dysfunction in one of these areas can certainly impact the other areas. And so over the years, there was more research and more recognition of this interrelatedness. And so now we recognize an entity called relative energy deficiency in sports. So you can see over in this area here how there's still this female athlete triad component to it, recognizing the interrelatedness of energy availability, hormonal health and menstrual health, as well as bone health. We also recognize the other physiologic implications of low energy availability, and recognizing how important that is in treating bone stress injuries, but also other injuries and other pathophysiology that's going on. Bone stress injuries occur as a result of an imbalance between bone formation and bone resorption. We know that bone is a dynamic tissue that's constantly remodeling. It's a balance between osteoblastic cells that stimulate bone formation and osteoclasts that stimulate bone resorption. And so estrogen is necessary to support the osteoblast function with building bone. So in circumstances where there's a low estrogen state or absence of estrogen that we see with low energy availability, we see an increased risk of bone stress injuries, or maybe there's a delay in healing as if an athlete sustains a bone stress injury. There was a study done in 2015 looking at 175 females between the age of 14 and 25. And they found that about 40% of athletes who had some estrogen dysfunction and low levels of estrogen had a history of stress fracture, and only about 6% of athletes that were hormonally replete had a history of stress fracture. So that was a statistically greater instance of stress fracture in the amenorrheic compared with eumenorrheic athletes. So when I see an athlete and a dancer with a bone stress injury, I actually do a very extensive history to try and identify these different risk factors and make sure that we are treating everything appropriately to, like I say, treat the injury at hand, but also try and prevent recurrence and promote health in general, better health in general. So we go through an extensive hormonal health, weight health, diet history, a bone health history, history of stress fractures, low energy fractures, go through a medical history. So there are certainly other underlying medical conditions that can contribute to low bone mineral density. So going through and making sure that those aren't contributory things like thyroid problems or digestive problems. A list of medications can be helpful. And then a family history. So as we talked about, one of the intrinsic risk factors can be related to genetics. And so getting an idea of family history that may predispose to a concern there. And then a training history. So those extrinsic risk factors that can also contribute to these injuries, getting a good sense of where the athlete is can be helpful. This is a list of labs, and so this is very exhaustive. This is not something you do on every dancer that comes in with a stress injury, but I put this up there to highlight that oftentimes we do some labs. So we do some baseline labs to get a sense of what their vitamin D looks like, or make sure that their thyroid function is normal. So we do oftentimes with a bone stress injury, depending on the circumstances, we will send some baseline labs to make sure that we're understanding everything that's involved. So when to suspect a bone stress injury? So that can be a hard, sometimes a hard thing to differentiate, because dancers really do work through a lot of pain. So a couple of things to really think about: if there's a gradual onset of pain that may not be associated with an injury, and there's an exacerbation of symptoms with high impact loading, so landing, jumps, that kind of thing is more painful with a bone stress injury. That amount of ground force going up through the bone exacerbates symptoms. And then there's bony tenderness, palpation right over the bone. So if you're able to push right over it and their pain is worse, versus kind of differentiating between the soft tissue structures that are nearby. Oftentimes you got to get very specific, pushing right over the bone versus the soft tissues right next to them, right next to the bone, to get a good sense of what's your suspicion that this is actually bony or more of a soft tissue concern. As symptoms progress, you may notice some swelling and then increasing pain with walking. So how do we diagnose these injuries? Oftentimes we're starting with an X-ray. X-rays oftentimes are actually normal early on in bone stress injuries. So the times that you start to see evidence of a bone stress injury is where there's actually a crack through the bone, or what we call periosteal reaction along the edge of the bone, indicating that there's some healing going on from an injury to the bone. But if you're early enough into the injury, or it hasn't kind of progressed to the point where you crack through the bone, then the X-rays may be negative. So if there's a high enough suspicion, then usually we're getting an MRI. So on the MRI, you get much more better characterization of what the bone and the soft tissues look like. So it can help differentiate some of those other injuries. And it also helps you to understand the extent of the injury. So, what parts of the bone are involved? Is it the marrow or the cortex? It gives you a sense of how long they may need to be out from dance. So MRIs can give you a lot of very helpful information. And then also, sometimes we do things like CT scans or bone scans. We have really kind of tended towards MRI. So MRI is a magnet. It's not radiation. So that part is a positive. Plus it gives you a lot of good soft tissue information. CT scans and bone scans are very helpful for very specific bony information. And so in certain instances, they can be helpful, but generally speaking, for kind of initial diagnostic purposes, MRI is quite helpful. So treatment depends a lot on the location and the degree of injury. So again, that MRI is helpful in helping you understand the degree of injury. But oftentimes we're using a walking boot for some period of time, crutches, avoiding high impact activity. And bone stress injuries are usually something that will keep a dancer out of dance. So a lower extremity bone stress injury. There aren't a lot of things that we like to kind of keep dancers out of dance for, but certainly bone stress injury is one of those things that, at least for a period of time, benefits from a period of rest to really let that bone heal. And then, as Dr. McDougall just highlighted, addressing other concerns, energy deficits, restoring estrogen balance to promote optimal bone health, optimizing calcium and vitamin D, and I can't overstate the importance of physical therapy, biomechanics, all of that. This is just to highlight, just the importance of recognizing the other things that contribute to a bone stress injury. We see that these are very commonly recurrent injuries. So 21% of bone stress injuries are recurrent injuries, and they can happen at times that are not ideal towards the end, right as the performance is coming up or something like that. So if we can find ways of identifying risk factors and really helping to prevent these injuries, it really supports the dancer and being able to do what they love. Reiterating Dr. McDougall's point, this is really a team approach, sports medicine, nutrition. Oftentimes from a physician standpoint, if there are certain hormonal factors at play, will involve endocrinology. Bone health concerns will involve endocrinology, OBGYN, physical therapy, always working very closely together with physical therapy, athletic trainers, and sports psychology. Thank you so much for your attention. Our last speaker, we get to chat again with Dr. Blackman and Dr. Faulkner. They are going to give us a behind the scenes look at the Atlanta Ballet, including touching upon some of the implications of COVID, and they'll be our last talk for today. Thank you to everybody for sticking around. We will have a few minutes for question and answer at the end after this last talk. Thank you so much.
Thank you, Dr. Gleason. All right, Emma, you're in charge of slides again.
Here we go.
All right, so as we mentioned earlier, and Dr. Gleason, thanks so much for putting up that slide. Emma and I are partners at a new clinic called Atlanta Dance Medicine, and we did want to point out that although we've opened this clinic, that was never really our intention. We started Atlanta Dance Medicine as an educational and collaborative platform. So we have a new clinic up in Roswell where we have 8 therapists that work on an extremely part-time basis. And our purpose really is to be a resource for dancers in the Atlanta community and even all over the Southeast to find physical therapy. So we refer out to PTs in our group and in our network all over the city and in the surrounding states. So please reach out if you need anything. Atlanta Ballet was really the initial way that we got plugged into the dance community in Atlanta, and that's what we want to tell you about today. So how in the heck do we get here? I get asked this question all the time at different dance medicine meetings and from students. And it really is sort of a long drawn out story, but I'll try to make it short and sweet. So when I went to PT school at Emory, a very long time ago, I started in 2002. I initially went into physical therapy thinking that I was going to do neurological rehab and stroke and spinal cord, and then quickly realized while I was in PT school that I missed the dance world significantly and I missed orthopedics. So I decided to sort of turn my path, and I decided I wanted to be an orthopedic physical therapist specializing in dancers and performing arts. So when I graduated from Emory, I started looking for mentors. There were not many in Atlanta, but I had one mentor say, if you want to rehab dancers, you need to get trained in Pilates. So I signed up for training under Polestar Pilates, which is run by a former professional dancer who also happens to be a physical therapist. And while I was in my Pilates training, I actually met the physical therapist that then was serving Atlanta Ballet. And I asked if I could shadow her or hang out with her or do anything with her. And she really was not open to that. So I made a promise to myself at that point in my career, this was in 2005, that if I ever did become a dance medicine physical therapist, that I would be really open to students and younger colleagues that wanted to learn and do what I did. So that's kind of what led us to where we are now. I started taking classes through Harkness in New York City, which is through the Hospital for Special Surgeries. They really specialize in all dance injuries and offer continuing education to PTs and physicians, athletic trainers, dietitians, all types of healthcare professionals specializing in dancers. So when I came back from those courses, I decided to stay far, far away from Atlanta Ballet. And I really started marketing myself to all of the dance studios around Atlanta. So I would go in on Saturday mornings and do triage and screening appointments. I would do injury prevention workshops for these younger dancers, and really got plugged in this way, not only in the ballet world, but in the Irish dance world as well. And then I got invited to speak at a sports medicine symposium through Emory. It was a female athlete interdisciplinary sports medicine symposium. When was this, Emma?
2012.
2012. Okay, so we fast forwarded a few years here, and I met Emma Faulkner. She was doing check-in, and she had her arm in a sling, and she said, "Hi, I'm Emma. I want to be you when I grow up." And I said, "Okay, Emma." And at that point, I had already started taking directed study students in dance medicine from Emory. Actually, Megan Gerhardt, who is one of our therapists at ADM, stalked me and asked to develop a directed study. So I was already accustomed to taking students and having them follow me around. And Emma was aggressive, if nothing else, and asked if she could start shadowing me and be my student. So we started working together that year. She was my short-term student and then became my long-term student. And while she was my long-term student, we started covering events. So we were working with dance competitions, dance performances. We were covering backstage, doing informational sessions, and even covering Irish dance competitions, which was really fun. And during that same time period, the PT that had been covering Atlanta Ballet actually left. And at the time, I was treating one of their ballet mistresses, who you can see there in the middle. And she called and she said, we need you like yesterday. So Emma and I packed our bags and we started covering Atlanta Ballet for 8 hours a week at that point. And that was back in 2014. Mm-hmm. So we made it work and became the PTs for Atlanta Ballet. And Emma was still a student at that point. There's no way I could have started that project without her. And she's been integral in us covering Atlanta Ballet ever since.
So yeah, after I stalked Mandy and decided that I really wanted to be her and bought her, I don't even know, 1,000 cups of coffee and chased her around her table, we picked up with Atlanta Ballet, but we also joined quite a few of these other groups. And these are all great resources for any of you guys interested in dance medicine or performing arts medicine. So we're big members of IADAMS and we present frequently at their conferences all over the world. I even took my honeymoon to IADAMS in 2018 in Helsinki, Finland. And then another one that we really have become very engaged with is the Dance USA Task Force on Dancer Health. So that is a group of physicians, PTs, ATCs, dietitians, a couple other allied health professionals that really focus on the health and well-being of the professional dance world, which is really interesting because there's a lot of injury prevention and work with the younger dancers, but this group is very targeted to our professionals. We also are members of the POSIG group, which is the Performing Arts Special Interest Group, which is a subsection of the ortho section of the APTA. So it's all physical therapists with interest in performing arts. And then a newer one that we've recently become a group or a member of is PAMA. So that's the Performing Arts Medical Association. And that is a group that works with all performing arts. So actors, dancers, singers, vocalists, musicians, all groups of performing artists. So it's very fascinating. And we've learned a lot about not just dancers in that group. So these are great places to plug in if you're interested. And please ask us questions about those if you have any. I'm just going to run through a couple pictures just because it's really fun. So this was my first IADAMS in Pittsburgh. So I was actually still a student. I just graduated. So this was my first big presentation. And so we had a lot of fun there. This is some Dance USA photos. So this is the task force on dancer health. So these are the PTs from Boston Ballet, the PTs from San Francisco Ballet, the physicians that work with Miami City Ballet. So this is a really cool network of people that we've become very plugged in with, and they've been actually really integral lately in some of the sort of COVID issues that have popped up with professional dancers. And Mandy's going to give us a rundown on that in a bit. And then another thing that happened for me, especially, is that Mandy introduced me to her mentors, and then they became my mentors as well. And now our mentors are some of our best friends, which is an amazing thing. So the picture here, so this is Sally Riddell. She is the head of the Emory dance department. And so I actually now work for her teaching in the Emory dance department. And then over here we have Heather Southwick, who used to be the physical therapist for Boston Ballet for 20 plus years, and now is working at the newly started McKaylee Institute up in Boston. IADMs all over the world. It's been really interesting to meet with people in the United States that work with dance medicine, but also abroad, because dance in the US is kind of considered, I don't know the right word, a fluffy career, a performing artist. Oh, you're an artist. Whereas in other countries, arts are subsidized by the government and they're seen as a lot more important. So it's been really interesting learning and seeing how performing arts is treated in different places around the world. And now we've also kind of gathered other students. So I've been able to take on students. Dr. McDougall was one of my students. And so now we just have this really cool group of people that we've either been trained by or have trained that now work all over the city. So one thing that's really interesting about treating Atlanta Ballet, so I'm kind of going to dive into Atlanta Ballet, is treating backstage. So treating backstage is very different than treating in a clinical setting. Oftentimes you're shoved in a green room, which is sometimes not more than a closet, with your table and your gear, and you're treating dancers really quickly. And basically the goal is to patch them up and get them back out on stage. There's not a lot of the rehab piece happening backstage. And some of the interesting things that we've seen that I didn't even think to learn about or to make note of is, you know, dancers are working with strange costumes. Some of these contemporary ballet costumes have almost like hula hoops around them in the tutus, or they have, you know, odd accessories that may cause an injury that we wouldn't necessarily think about. We've had performances at Atlanta Ballet that have required folding chairs on the stage, with dancers jumping onto and off of the folding chairs in the middle of a performance. So that's a little scary to watch. And another one that I'm thinking about is for our new Nutcracker, we have a lot of flying. So we have dancers in harnesses and they're rigged up to fly off the stage, which is beautiful and magical, until the set doesn't go with them and they crash into a metal beam. So some things that you may not necessarily consider as a risk for injury can be a major problem in the professional dance world. So for that, we are all trained in emergency medical response. So this was a course that we got to go take out in Tucson, Arizona a couple of years ago. And we learned a lot about basic first aid and treatment of some of those major acute injuries in the moment. So we can see Dr. Blackman over there pretending she was a football player at some point, learning how to, you know, splint the cervical spine while taking a helmet on and off. Not necessarily something we'll have to do in ballet, I hope. But you never know with some of the contemporary works out there. They may throw a football helmet on a dancer one of these days. Atlanta Ballet performs in two main places. So it used to be the Fox for Nutcracker, and then Cobb Energy Center for all of our other performances. Obviously this year has been a little different with COVID. We're hoping to actually have an outdoor performance coming up in a couple of months. And then fingers crossed by next year, we'll get back to our typical performances. but Nutcracker will be moving into the Cobb Energy Center. These theaters are gorgeous, but they have interesting risk factors. You know, we use a live orchestra often, so the front of the stage, if a dancer gets too far forward, there's a 16 to 20 foot drop onto concrete or musicians underneath them. So there's really interesting things to think about as far as safety of our dancers inside a theater setting. So those are just a couple backstage pictures. And like I said, treating backstage is a lot different than treating in a clinical setting. So it's a lot of tape them up and get them back on stage. We utilize dry needling a lot of soft tissue techniques. And our major goal is to get that dancer on stage with the support they need so that they can perform safely. And then we're able to rehab them a little bit better afterward. And I will say, we have had to pull some dancers backstage right before a show. And that is one of the hardest parts, I think, for me, is telling a dancer that they're not safe to go on stage and making that call for their safety.
So Atlanta Ballet is not historically a touring company. Some of our colleagues in the dance medicine world tour full time. So when you think about Alvin Ailey, which is primarily a touring company, or even Miami City Ballet tours around Florida on the regular, that is not our experience with Atlanta Ballet. But this past year, well, 2019, Atlanta Ballet had the opportunity to perform Nutcracker at the Kennedy Center in DC. So it was my first time going on tour with them. I've been on tour with other groups, including musical groups, but never with our dancers. So it was really fun to spend the week of Thanksgiving in the Kennedy Center, which is a pretty magical place. And again, I was able to pull in colleagues from our dance medicine connection. So I knew the dance med PTs up at Johns Hopkins in the DC area, and they were able to come assist me. And then one of our former students, Tiernan Thomas, was also working in DC at the time. So she was able to come help. So we set up our same little room in the green room in the Kennedy Center and got to treat there for an entire week, which was really fun and exciting. Again, you're seeing different issues. So the dancers were walking almost a mile to and from their hotel to the Kennedy Center for each performance and each class. And it was extremely cold that week. It was in the 20s. So I was dealing with a lot of cold injuries. Plus it's a different stage, and our Nutcracker set, which is new to these dancers, was set up a little bit differently on the Kennedy Center stage than what they were accustomed to at the Fox. Different lighting, different flooring. So just different variables that go into some of the injuries we saw during that particular performance. But we've been very lucky to be able to cover Atlanta Ballet. So oftentimes we'll have our therapists sign up for triage appointments, meaning we're treating in between performances or prior to performances. But then those therapists who are trained in emergency medical response get to stay and watch the performances. So then we get to get dressed up. A lot of times we bring our friends. You can see that top middle picture is Dr. Linda Bluestein, who came to visit us. This was actually the last performance we all saw before COVID hit. So that was pretty special. We've gotten to host some of our colleagues in the dance medicine world. But then that bottom picture you can see is a performance called Cacti, which has been one of the more unnerving pieces as therapists to watch, because our dancers are lifting extremely heavy boxes and having to navigate some really interesting positions during that performance. So Emma and I end up holding our breath a good bit while we're sitting in the audience watching some of this stuff. So impact of COVID. Like I mentioned, COVID has, as we all know, affected everybody all over the world, but it's especially affected the performing arts community. So Emma and I were actually in the studios treating on the morning of March 16th when we got the call that we were shutting down for 2 weeks. So we sent our dancers home with some ice packs, and one of them took our physio ball and one took our balance boards, and we said, okay guys, we'll see you in 2 weeks. And of course that did not happen. So the dancers very quickly transitioned into virtual class and even virtual PT, which those PTs and athletic trainers on the call know that that is not an easy thing to do. The dancers were given Marley for flooring for practice at home, but we heard a lot of issues from the very beginning of COVID of, you know, they didn't have a bar, they weren't on a sprung floor, they were very limited in their space. A lot of them, there were multiple dancers living in very small apartments. So there were definitely restrictions with them being able to keep up their training, access physical therapy, access other types of care, but then also keep up with their conditioning, strength training, and cross training during this time. So Emma mentioned this earlier, but around May of 2020, a few of our colleagues from the Dance USA Task Force on Dancer Health were able to really collaborate and pull in information coming from the US Olympic Committee, NCAA, the CDC, World Health Organization, and really combine all of that information into a few papers that offered guidance for returning to the studios and returning to dance during COVID, as well as keeping up with conditioning while we were still shut down and outside the studios. So those have been extremely integral all over the world. They're actually the most accessed papers on the Dance USA website, and we've gotten to do a number of forums and Q&As with the dance community, executive directors, artistic directors, et cetera, as the healthcare representatives for this incredible group. So that's been really interesting. And it's actually what got Emma and I our opportunity to open our new studio up in Roswell, because we sent out these guidelines to all of the studios around the Atlanta area with the knowledge that although these were directed at professional dancers, many of these concepts applied to our pediatric and adolescent dancers as well. So we've gotten a great feedback from our Atlanta dance community on how helpful and integral those were in getting these dancers back in the studio, including my own stepdaughter, which I think if she were still dancing at home, both of us would be very unhappy. So we reopened at Atlanta Ballet a month late. We reopened in September 2020 with pods. So the dancers were very divided. Roommates and relationships were taken into an account when they designed those pods to try to keep cross mixing of the pods as minimal as possible. They came back taking just class at the very beginning and then slowly transitioned into dancer-based choreography. So they were able to do a few virtual performances here in the past few months, and even back in the fall with some dancer-based choreography where they were actually getting to choreograph on their colleagues. We've had two major virtual performances, both filmed at the Rialto, which has been interesting because that is not a theater that's traditionally used for dance. So that's caused some repetitive force injuries because of the flooring there. And then, as Emma mentioned, we are hoping to have our first in-person with audience performance in May at Georgia Tech, which will be outside, I believe, on top of a parking deck, which will bring its own interesting variables. Our dancers are doing daily screening. They're encouraged to do COVID testing with symptoms. We have had to shut down a few times due to some COVID cases, which I think is the case for a lot of organizations, which has caused some intermittent shutdowns. The dancers are off for a week, they're off for 2 weeks, maybe they're doing virtual class and they come back. So that can really lead to different types of injuries and issues as well. I know the mental health implications for that have also been significant. So we're dealing with a lot with these dancers. We have 38 professionals that we take care of, and then another 18 in our second company. But we are able to do physical therapy in person, and we're moving along, and we're all doing okay as we can right now. So these are just a few pictures of how we have functioned during COVID. We use hypochlorous acid treatment that I make myself. We fog the room, which you can see our colleague Mark fogging the room down there on the right. It's just been really interesting changing our protocols to make sure that we're keeping everybody safe, masking, cleaning regularly, spreading out PT appointments, and then bringing in Lucy, our emotional support dog, which has been really great for our mental health and the mental health of our dancers. So again, a lot of people, is this you, Emma, or is this me?
It's you.
Okay. A lot of people ask us, how do I do what you do? And I gave a talk similar to this recently to our Physical Therapy Association of Georgia student group. So I borrowed this slide from there. But first of all is to learn the art. So if you want to treat dancers, you need to know something about dance. And I think all of our speakers this morning, Jennifer and Ann and others, have really shown a nice light into some of the more interesting aspects of dance and what makes it unique. So learn dance first. But then also, if you're a physical therapist or athletic trainer or physician, be the best orthopedic physician, athletic trainer, PT you can be. So really learning the basics so that you can apply those basics to dancers is going to be really important. You got to walk before you run, or you have to chaîné before you pirouette. And then take specialized courses. So we mentioned Harkness. Emma mentioned some of those organizations that we're involved in that all have resources for learning dance medicine. And then I'll tell you a little bit about a course that Atlanta Dance Medicine hosts as well. So just finding those specialized courses like this to get that information is going to be really helpful. And then the next couple are sort of connected. So shadowing and volunteering, joining related organizations, networking, and finding a mentor are going to be so important. If I hadn't had mentors help me very early in my career, Heather Southwick at Boston Ballet, and those types of people who are willing to just take me on and teach me and guide me, I would never be where I am today. And I think that the students that Emma and I have mentored would say the same about us. So just those meetings and those networking opportunities can be so integral in finding jobs and finding volunteer opportunities for you to learn more. If you get the chance to become emergency medically trained, the athletic trainers and the physicians obviously don't need that, but PTs, it's not in our normal training. So I would encourage you to go get EMR trained so that you can provide backstage coverage, which is just a whole different type of experience in the performing arts world. And then once you get there, we would encourage you to give back. So we take students, we volunteer, we serve on committees, we serve on organizations. And I think that that's been the most important thing in our dance medicine road and how we got here. So I mentioned our course right before COVID in 2020. Emma and I did our inaugural Dance Medicine Essentials course, which many of the people here, including Dr. Gleason and Val Schonberg, spoke at that course for us. We're going to make it 2 days this year, so it'll be in July. We'll do a didactic day and a practical day, and many of the people you heard today will be speaking at that course as well. So if you're interested in that, please follow us on Instagram and Facebook, and you'll get more information. Please reach out to us anytime. Those are our Atlanta Dance Medicine email addresses. And then we have a website and then our Instagram, which Ann runs as well. So we encourage you to follow us or reach out if you'd like to connect.
Thanks for having us, you guys.
Thank you both for sharing your unique journeys and just so much insight and just unique information that a lot of us, it's just a unique experience. So thank you very much.